Thank you very much. Good morning. Good morning. I hope everyone can find a seat. There's still lots of good ones in the front. And as people are coming in, I'll do a few housekeeping things. My name is Dr. Lynn Beattie, and I'm the former director of the Alzheimer Clinic. And I am very privileged to be here at this podium today to welcome you to this forum today. We will be, I believe, just using this room, given the numbers in our audience. And I would like to point out that each person should have 2 cards, or you can borrow them from someone else if you use yours. And as we go through the talks today, please feel free to write any questions on the cards, and then somebody will be coming up and down the aisles to collect the questions, so that we'll be able to have a relatively brief question and answer period, but we would like to be able to sort them out and do some priority questions. There is the possibility of participating in clinical trials or any of our the clinical research programs, and on your desk is a 3-page sheet like this, and you can fill out your name at the end of it if you're interested in being contacted. In addition to that, you can put your name and address and email on one of these cards and leave it at the contact information booth in the atrium, and then you could be contacted for any other kinds of special events that the clinic puts on or participates in. We are, I think, in the process, or I can say the clinic, are in the process of building a good mailing list and a good contact list. And so it's really important, if you are interested in participating in things that you do, try and take advantage of this to get in touch. And there is also an email, card.clinic@ubc.ca, card.clinic@ubc.ca, if anyone wants to be in touch. Don't forget, we have a coffee break, and there are going to be posters in the atrium, and some of you may have already seen some of the posters on your way in here. And the people that are responsible for the posters will probably be nearby, so if you have any specific questions, feel free to ask them. In addition to that, if you have any questions that arise during the talks and you're not able to have your question answered, our speakers will be around, and you're welcome to talk to them at any time. I think we have most of the people in the room now, and I think we should get started because we do have a rather tight timetable. I would like to introduce first Dr. Howard Feldman, who's the director of our Clinic for Alzheimer's Disease and Related Disorders, and he also has huge responsibilities in the Dean's office, and he has clinical responsibilities in the Division of Neurology, but we're very pleased to welcome him as the head of the clinic today. Dr. Feldman.
Thank you. Good morning, everyone. It is particularly nice to see everyone. The team that has put this event together has had great apprehension. What if we put everything together and nobody comes? And there was some uncertainty about registration versus not registering for the meeting, so it really is great to see everybody, and thank you for joining us. I thought it would be useful to start the morning by telling you a little bit about our clinic. Many of you in the room have interacted with us, but perhaps don't have the full view of the activities that go on outside of the particular ways that you interact with us. I'm going to take about 10 minutes to give you a bit of a landscape view of the things that we're working on, and it will set the stage for a lot of the talks that you hear this morning. So one of the very exciting things that's changed since we last assembled in this room together is that we now get to work in this fabulous new iconic building on the UBC campus called the Javad Moafagian Center for Brain Health. And one of the tests will be to repeat that name after you leave today. Our vision behind this center was to really create an integrated environment where clinical care and research would be seamlessly provided. On the top floors of this building, we have fundamental research. So we have research that involves looking at models of disease, looks at basic mechanisms of disease, and looks at molecular genetics of disease. On the third floor of the building, we have a clinical research floor. Our clinic is on the second floor, and on the ground floor, or rather in the basement of the building, we have state-of-the-art platforms that will include a tissue bank and a brain bank. So we have the ability to start with patients on the second floor. Specimens may go up to the other floors of the building to be worked on. As our director of the center often says, earth-shattering discoveries will be made and they will be translated back and sent back down to the clinic for implementation. So that's the idea, and we've been working very hard since January 2014 when we moved in to bring that dream to reality. So we're very excited about that. Before we go too far today, I want to acknowledge the event sponsors. So in particular, I would like to call out Canada Direct Insurance, which has provided us some funding to host this event, as well as to the clinic who co-host the event. I would also like to recognize the important partners that we have. The center that I just showed you is a partnership between the University of British Columbia and Vancouver Coastal Health. It is our attempt to work between the two organizations and to create a seamless environment. We work with the Development Office, both at VGH UBC Hospital Foundation and the Faculty of Medicine Development Office. We have important partnerships with the Alzheimer Society of British Columbia and also interact frequently with Alzheimer Society Canada. And this is all housed within the Center for Brain Health. So this is really the only dedicated facility that exists at the moment in British Columbia with which to study and care for brain disorders. And as I've explained, this is an integrated model of care that we're seeking. Now, one might say, so what's the real value proposition of this new clinic? And I would point out that what's going to be very unique about it is that we will share space and are sharing space with adjacencies to Parkinson's disease, Alzheimer's disease, Huntington's disease. This morning it's likely that you'll hear that often within the aging brain there are multiple pathologies, some of which can be Parkinsonian, some of which can be cerebrovascular or stroke-related. Having proximity stimulates the discussion and the interaction around mechanisms. We share space with multiple sclerosis, and importantly have additionally our psychiatry colleagues, depression and bipolar disease, with whom we also will interact. So take, for example, an individual who has Parkinson's disease. Depression is very common, as is dementia. So what a great place to come if you have depression, Parkinson's disease, and dementia, because we have a whole suite of capabilities with which to address that problem. I've mentioned the state-of-the-art platforms that we have inside the building. This is very important. Many of you who have been to clinic consent to provide either clinical information to be uploaded to a database, anonymized and uploaded. You sometimes provide samples of DNA that we store and utilize for research. At the end of life, we solicit brain donations to try and verify diagnosis, as well as to use the tissue to try and advance our research. The commitment that we share across all of the different programs that I've told you about is that they're all intended to gather and assemble data on everyone that we see. So imagine for a moment that through our genetic counseling, we've seen more than 30,000 families and have drawn out family histories. What a rich resource that is, particularly when it's associated to some DNA with which we can make world-class discoveries. And there are some examples that I will show you. So these are very important platforms that we have within the center. We make a deep commitment. We understand that within our own mission, we aspire to excellence in clinical care. We have a deep commitment to research, to education, to the training of health professionals. So if you come and see us, you may see students of various kinds, trainees from all over the world that come to study and to work with us. We also have a commitment to knowledge translation. It is said that 70% of the findings in research never make it to clinical care. We intend to try and narrow that gap so that when there are discoveries that are pertinent or even discoveries that we make, we're going to work very hard to make sure that they enter into the patient experience. And we try and move research seamlessly into clinical care. Our research, as we articulated, is focused on the prevention of dementia and cognitive impairment. So we now have a lot of evidence that the pathology of Alzheimer's disease will build up 1 to 2 decades before the first symptoms. We know that there is a window of opportunity potentially to think about prevention and to mobilize around it, so we're very strong on that, and you'll hear some mention of this as we go along this morning. We want to improve the care of those that are affected with the disease. We never lose sight of that. That's core to our mission. And we also want to work at the fundamental biology of these diseases. We know they're complex. We know it can be discouraging when progress is slow, particularly as we're now in a period where there have not been new treatments in more than a decade. But I can assure you that the pipeline is full and we are working avidly on this. Our clinical program, for those of you that come to see us clinically, is based around multidisciplinary care. We have the privilege of having a very strong team that includes social work, genetics and genetic counseling, neuropsychology, neurology, geriatrics, and geriatric psychiatry. So we have a range of talent and capabilities. We also work with community partners. It's very important. We can't do everything in one place, and it really does require a community to look after dementia. It's a very complex disorder with a lot of behavioral, social, and other issues that will come up. We are provided with a core amount of administrative support from the hospital. It is interesting to think for a moment about where the reach for research in neuroscience and in Alzheimer's goes, because we end up collaborating with radiologists and physicists, computer scientists, mathematicians, cognitive psychology, neuroethics, engineering, and our other neurodegenerative disorders. So, the brain's a complicated organ, and it does take a complex set of skills to deal with it. To give you a sense of the landscape of what we're working in, you all have a paper in front of you that describes specific studies, but I would break them into about 4 large groupings. So we do observational research. This is very important. So everybody that comes to clinic has an opportunity to donate their clinical information that we scrub names off of, but imagine how strong it is when we can put all the data together. We've worked very intensively on the subtype of dementia called frontotemporal dementia. We've made some very important discoveries in that field, and we'll touch on some of that. The notion of mixed dementia, so those are the observational studies where we follow people in a naturalistic setting to try and understand what the illness looks like, both in its earliest stages as it unfolds. Our goal is to try and find interventions that change the curves. We're interested in lifestyle interventions, and you'll hear this morning about exercise. Other days we can talk about things like music. We're looking at medical food interventions, things that might stimulate the brain that have unique pathways, and we're working on a medium chain triglyceride study at the moment. And then there's a host of pharmaceuticals. So just to conclude, I want to show you where some of the impact of our research has landed. The work that we've done has enabled some new diagnostic criteria to be developed for Alzheimer's disease. And I draw your attention to this space called preclinical Alzheimer's disease or asymptomatic at risk. This is a period of about 2 decades where individuals are beginning to develop the pathology of the disease but do not yet have any symptoms. And you can see, for example, from the red curve line that the amount of amyloid beta that you'll hear about this morning has actually deposited quite significantly well before the first symptom, and some of the other pathologies similarly. These criteria have now spurred something like 25 to 30 clinical trials aimed at prevention of Alzheimer's disease and early intervention, something we couldn't even dream about 10 years ago. I talked about frontotemporal dementia, and we discovered through some of our family studies a gene that not only causes frontotemporal dementia, but also causes the disorder amyotrophic lateral sclerosis. And this research has conclusively informed us that these diseases actually sit together on a continuum. So they are part of the same disease spectrum, and the research that we've done has confirmed that. So this is really just a landscape view. You'll see it cycling through. This is really by way of acknowledging a clinical team, a research team, collaborators within the building, the administrative team, the support that we get from a variety of funding agencies. We bring about $1 million of research funds in every year to the clinic through our active grants. Most importantly, we thank you as our key stakeholders, patients, families, and community. It's your trust that enables us to provide clinical care and also to stimulate our research environment and participate in our studies. So thank you.
Thank you very much, Howard. Now I'd like to introduce Maria Howard, who's the CEO of the Alzheimer's Society of British Columbia. And they just had a very special announcement yesterday, and I hope she'll mention that. And many of you may have been involved also with First Link, and I think she might mention that. Maria Howard.
Good morning, and thank you, Lynn, and thank you, Howard. It's really exciting to be here and come to say a few words. Every year, our society looks forward to this annual event to hear what is happening at the clinic. And we are very appreciative of what is happening at the clinic and at the Centre for Brain Health. It makes a big difference. In the province of BC, we know that people that have been diagnosed with Alzheimer's or other dementia are probably over 70,000. And if we think about those individuals and their care teams, their supports, their families, that number doubles, it triples, it balloons. And that's quite amazing when you think of all those individuals in our province who are living with this disease and struggling to go along the dementia journey. We know that their experiences, what they will have as barriers, as limitations, how it will impact their life, their work, their family, is all completely unique. Even though the disease is very much similar, their experience is their own, and how they will adjust and how they will adapt will always be unique. But what we do know is that the two things that we all need in Alzheimer's and dementia is help and hope. Those are the two essential things that will help people go through this journey much better. And that is why the mission, the tagline for our society is help for today, hope for tomorrow. And that is also exactly what the Alzheimer Clinic here at the campus does too. And it's amazing because that common landscape, that shared ground, is what is helping us to move forward and what is helping the clinic to move forward and help people in British Columbia. How we do that is through a number of different things. Our first link, as Lynn mentioned, is our early intervention services. It's a way for people who have been diagnosed with dementia through the clinics, through their physicians, to come through to our society and receive information and education and support of where they can go to begin to figure out what this means in their life. And the first link, early intervention services, is something that the clinic here at UBC uses very frequently, and we are on a regular basis receiving referrals from people across the province and interacting with these families and helping them out. We also have a dementia helpline. People can phone and ask questions about the disease. They may have a diagnosis, they may be worried, they may have a friend and they don't know what to do. And we are often providing them with information and questions that they can take to their doctors or go to the clinic and know how to share their experience with the health professionals and make that then a better interaction. One of the initiatives we have just recently, and it's the exciting announcement that Lynn referenced, is what is called Dementia-Friendly Communities. And it's this new initiative that really dementia is not just a senior's disease. It is something that touches a whole entire community's life. So we are working very closely with a number of communities, but specifically with a number of municipalities in BC, to train their city councils, to train specific staff to actually begin to create environments for people with dementia, and their supports can actually have better accessibility, more safety, more engagement. And it's a wonderful thing. And this Monday, New Westminster City Council was the first city council in BC to step up and be trained as a dementia-friendly community. And it's really a beginning that we are so excited. And as we go out into the province and talk to the communities, often researchers from the clinic here join us, and they're able to share practical and scientific knowledge that really helps the community understand how just does Alzheimer and dementia touch us. But the research, which is exactly why you're all here today, is also very important for us. Much of the fundraising and the donations that we're bringing in are coming back to the researchers who are really working hard to find a cause that can cure. And a number of the researchers here at UBC are funded through the dollars that people give to the Alzheimer's Society. But there's another side of that. In interacting with people with the disease, we are coming to the clinic and to the researchers and bringing their stories and their experiences so that the researchers here can better understand what impact they are having as they are looking for things. And so that relationship between the patient or the person living with Alzheimer's and dementia and the researcher can come together in a shared world. And that is exactly the concept of the center, and that is why we are so appreciative to be here and be a part of it. It's an exciting day for us, and we are just so supportive of the ability to work together. So thank you, and enjoy the day. Thank you.
Thank you very much, Maria. I'd now like to introduce Dr. Håkan Nygaard. Dr. Nygaard came to us from Yale University, and he is the first professor, Fipke professor, and he is of special interest in research and clinical practice. And as Maria was talking about, keeping the patients and the research together, and he epitomizes that. He's a clinical researcher. Dr. Nygaard.
Good morning, everyone, and welcome to this forum. I'm very happy today to share some of the really exciting advances that we've made in diagnosing Alzheimer's disease, and how these changes and how these advances will really reshape the future of Alzheimer diagnostic and really the future of the way we treat this disease. So it used to be that a diagnosis of Alzheimer's disease from a definitive standpoint always involved autopsy. So you may have had some loved ones who have had an autopsy, and we continue to do that as it gives us lots of valuable information about the mechanism of disease. But you had to have deposits of this protein, as it's shown here on the left, to be diagnosed with the definitive diagnosis of Alzheimer's disease. This is called beta amyloid, and you'll hear lots about beta amyloid today. But these deposits diffusely in the brain as Alzheimer's disease progresses. And when you get to autopsy, you see millions of these located in the brain. So we also see some other pathologic deposits. We won't talk much about these today, but these are called neurofibrillary tangles. And there's an intense research now trying to understand what these do. But instead of going to autopsy, we can now look at amyloid in a living person. And that gives us the ability to follow amyloid deposits over the lifetime instead of looking just at one time point. And that's done through a technology called PET imaging. And you don't need to know the details of PET imaging. In fact, the physics I don't understand well myself. But think of it as simply imaging a dye. So if you could somehow come up with a dye that attaches to beta amyloid in the brain, then you can image that. You could get a sense of what's going on in the brain. And that's exactly how this works. So think again of a dye that binds to beta amyloid, and it gives you simply a picture of where the amyloid is in the brain. And that's what's illustrated here. This is actually from a real patient. And if you look at the right here, what a normal person should look like, or a person who does not have amyloid deposits, you shouldn't see any color at all. So the dye doesn't bind to anything in the brain. Whereas someone with Alzheimer's disease who has amyloid deposits, you see the red indicates very high levels of amyloid, and the blue indicates no. So you can see that using this technology, you can image amyloid in the brain in a living person. And it doesn't have to be if you're 60 or 70 or 80 with memory problems. It can really be any time during life. And that's what makes this technology so exciting. There's another type of imaging called, it's also a PET scan, but now instead of having a dye that binds to amyloid, it binds to sugar instead. And the reason why that's important is because sugar is used by the brain extensively. So in order to keep the brain active, we have to use lots of sugar. And it should be taken up by the brain very homogeneously, which means that it should be taken up evenly throughout the brain. And that's what you can see here. If you see this black sort of ribbon here around the brain, this is what a normal person should look like. So the entire outside of the brain should have a nice, even black surface. But in this particular individual, can you see how this side, and that's really what we work very closely with radiologists, but they look at these images every day and they say, the one side is a little different than the other. And that's what you see here. So you see how this is much not as dark as this side. Is that pretty obvious to everyone? So we're looking with, if you would call it a sugar PET scan, we look at whether there's an even distribution, and when there's not, there's a particular pattern that correlates very well with amyloid deposition. So there's a pattern that correlates very well with Alzheimer progression. So we can use either scan. One measures amyloid directly, one is more of an indirect measure, but they all look at the same thing. Is there amyloid deposition in the brain, or are you at risk for developing Alzheimer's disease? And this is just another way of, maybe an easier way of looking at a sugar PET, where they've actually colored the areas that have reduced uptake of glucose. So what does this mean? So it means several things. I want to touch on what it means immediately from a diagnostic perspective first. So many individuals come to our clinic with mild symptoms. So you might have some memory problems. You may not find your car in the shopping mall parking lot. You may forget other things. So what is going on? What is my risk of developing Alzheimer's disease later on? And what is my risk of getting worse? And that is perhaps the most difficult question we get, and it is the question that patients of ours want to know the answer to. And you can use this technology to make some headway. It's not perfect, but it makes us better at predicting who will get worse, and it makes it better at predicting the underlying diagnosis. So I'm going to focus on this second point here. So if you have a particular type of mild memory disturbance, what is the risk of getting worse over a 3-year period? And you can see with a normal clinical exam, and this is taken from years of experience, it's about 12% in certain cases. If you add imaging to that, you significantly increase your accuracy, or the way you can predict who will get worse over time. And that's an important question to answer for patients. And perhaps even more importantly in many ways, if you have a negative PET scan, then your chances of getting worse is very low. And again, in many ways, this might be the most important information for patients. So if you undergo this type of testing and you're concerned, if you have a negative scan, then perhaps you can be less concerned because your chances of getting worse over a 5-year period is very, very low. And this is just illustrating that. So this particular study looked at individuals with very mild symptoms, and they followed them over 3 years. So one group had a positive scan, and one group had a negative scan. And in this case, when the line gets increases, it means that you're getting worse. So if you had a positive amyloid scan over a 3-year period, your cognitive performance or your memory or other things got worse. If you had a normal scan, as you can see here, there was really no change over a 3-year period. So again, if you have a negative scan, it really predicts that you're not going to have a negative outcome over the at least 3 to 5 years, but we think longer than that as well. But it also has a very significant impact, not just on diagnosing and predicting outcomes in patients who have some symptoms. It really informs research and where we want to start therapy. So this is the graph that Dr. Feldman shows. I think it's the most used graph in all of Alzheimer's research. I think it's hard to go to a talk these days without seeing this graph. But this is really decades of research looking at biomarkers. And the key question that was asked is, if you have someone who developed Alzheimer's disease and you look back 30 years, what can you see 30 years earlier that would predict that patient getting worse? And what was found was, as Dr. Feldman mentioned, 20 years, so think about that a little bit, 20 years before you have any symptoms, the disease really starts in the brain. 20 years before. So there's a very big room here to identify individuals who will get Alzheimer's disease and start intervention early. And that's what this technology really does for us. So if you think of a patient who is here now with mild symptoms or even has dementia, if you were to turn the clock back 20 years and you would find that person here, could you start a medicine to stop that process? And that's really what a lot of research are looking at now, trying to identify patients who are in this high-risk group and see if there's a medicine that can be used at that point to slow the progression. And this is using both PET scanning, which is here, and the glucose scan that I showed you before. Both of those modalities have a signal up to 20 years before symptoms start. So will everyone get this in midlife? I sort of liken it sometimes to a colonoscopy, which is now mainstream. Everyone gets it in their 50s. Are we all going to get an amyloid scan in our 50s? Well, not so fast. It's complicated. So, and that's why I focused on, if you have a negative scan, it's very useful to understand that you're not going to get worse. If you have a positive scan, however, it's a little more complicated. And the reason is this. What we've learned from various studies is that as you get older, you have an increase in deposition of amyloid without having the accompanying memory loss or dementia. So in the 80-year-old age group, if you're 80, you have about a 30% chance of having a positive amyloid scan without having dementia. So do those people who have a positive amyloid scan eventually get Alzheimer's disease? Well, we don't know yet. But obviously this is a big problem if you're going to use this as a positive predictive test. And there's a lot of work trying to understand, how we can best understand those who will get worse and those who don't with an amyloid scan. So that's the imaging aspect of this. There's one other aspect that have been worked out over the last decade, trying to predict again if you have mild symptoms who will get worse over time. And those are, we refer to as biomarkers, so measuring amyloid directly. And the way we can do that from the brain is sampling something called cerebrospinal fluid. And it turns out that the brain here it sort of swims in this CSF, as we call it for short. It's like a bath, and it extends down to the spinal cord. And that's nice for us because we can go in the lower back with a little needle and sample some cerebrospinal fluid. And that gives us an idea of the environment that the brain sits in, and it gives us access to measuring beta amyloid in the brain. So what research has shown is that there is an Alzheimer signature when it comes to these biomarkers. So just as I showed you with PET, there are certain patterns with PET imaging that would predict future decline. The same is the case for CSF biomarkers. So if you have a certain pattern of amyloid and this protein tau in the CSF, then that can predict worsening over time. And the measures are very closely related to the PET data that I showed you. So if you have this Alzheimer's signature, then your chances of getting worse is about the same. It's about 2/3 chance to get worse over time. But maybe more importantly, if you don't have this signature, then your chances of getting worse is much lower. So that's why what I would like to emphasize. So just to conclude this, amyloid PET, sugar PET or FDG PET, which is a technical term, and these biomarkers in the CSF can all predict if you're going to get worse and going to get Alzheimer's disease, but perhaps more importantly, if you don't have them, your chances of getting worse are very low. And finally, it will instruct when we intervene with medications once the medication is available, and perhaps this will be a screening method for everyone in midlife. Thank you very much.
Thank you. Remember, if you have questions, put them on the cards, and we'll have people going up and down the aisles. And if you need more cards, we have more cards available. Our next speaker is Dr. Philip Lee, who's a geriatrician, and many of you who come to the clinic may have met him. He's going to talk about uptake in current Alzheimer therapy. And we're always interested in what we can do to be better. Thank you, Dr. Lee.
Well, thank you very much for that introduction, Dr. Beatty. Let me begin by saying what a privilege it is to be part of this forum. Of course, I thank all of the conference organizers for putting together just so far a wonderful program. I very much look forward to the opportunity as well to interact with you during the break and during the question and answer period with the discussions which obviously are very important to us all and bring us here today. For my part, I'm going to be talking about some of the current Alzheimer's therapy, and over the course of the time that I have to share with you, I'd like to distinguish between what we're talking about, which is symptomatic management, and hopefully set the stage for some of the later presentations, which are really going to talk about the disease-modifying treatments, the things that are hopefully going to help us to prevent the disease in the future. What I will be focusing on is the currently available drug therapies. This is what we have available right now to prescribe to people with Alzheimer's dementia. One important distinction I want to say right off the bat is you're already hearing how we're pushing the envelope back in terms of how we identify people earlier on in the stage of Alzheimer's disease. What I'm focusing on are people who have definitive Alzheimer's disease in the context of symptoms that are bad enough to impact their daily function. In other words, having dementia. We're not speaking specifically about MCI, which is that sort of pre-dementia state. What I also want to start off by saying is that although I'll focus on medications, we fully recognize and endorse the fact that medications are only a small part of Alzheimer's symptomatic treatment. Earlier on, we heard Ms. Howard present on the importance of connecting with community resources and supports, and I can't say enough about how we really encourage that that is an essential part of Alzheimer's treatment. And on top of that, we're going to hear about some important lifestyle modifications and strategies that you may employ not only to treat symptoms, but hopefully to actually prevent the disease. So I think that even though we're going to focus on drugs, I just had to say that right up front because I do know that as part of treatment, it's sort of this whole approach that we take, and drugs are only one portion of that. But having said that, let's talk about these medications. We've already heard Dr. Nygaard refer to the presence of tau and amyloid within the brain. And this cartoon represents that. The tau accumulates within the brain cells called the neurons. The amyloid collects in the spaces between the brain cells and disrupts their function. So it's a combination of tau and amyloid that we focus on in terms of thinking about what causes the symptoms of Alzheimer's disease. But let's just say it's a bit more complicated than that. And that's why we're so lucky to have the researchers who know the ins and outs of the different pathways and can tell us, maybe even going back to what is the cause of Alzheimer's disease, even before tau and amyloid start to accumulate. What can we do to understand what causes it so we can be further ahead to understand how we can prevent it? But even if we can't necessarily prevent that process from starting, perhaps we can understand more of what therapies can we give to actually remove that amyloid, remove that tau, or decrease the damage that it does to the brain cells. And that's where we talk about disease modification. And I do know that Dr. Shung is going to present some very cutting-edge research in this field and touch upon what we're doing right now to advance that. But what we have right now are not disease-modifying treatments. The treatments we give don't halt the disease. They don't necessarily slow the accumulation of amyloid or tau, but that doesn't mean that they're not important treatments. What it does mean is that we can sort of focus on the symptoms, the downstream consequences of the accumulation of these changes in the brain to hopefully bring about some meaningful improvements in day-to-day life. With regards to symptom management, I like to break it down into cognition. So we think about memory, but it's also language. It could be how one plans one's day. It could be about how one processes visual information. It could be about behavior, mood, personality, or ultimately it's about function, what a person is able to do or not as capable of doing as they did before. Now again, if we focus on those symptoms, what do we have to offer that we could perhaps suggest that could be helpful in that regard? And really it comes down to right now 2 classes of medications. These are the cholinesterase inhibitors and an NMDA receptor antagonist. And I'm going to explain each of those categories in a bit more detail so that we all understand how these medications actually work. But before we do that, just a brief timeline in terms of how these were released. It was about the turn of the 20th century that Dr. Alzheimer's first described the clinical and pathological case which now bears his name, the disease called Alzheimer's disease. Well, it was really until the early 1980s that people began to realize that perhaps some of the changes in the chemical structure in the brain could be resulting in some of the symptoms, which ultimately led to the release of the first cholinesterase inhibitor, which was made available in about 1993, and that was Tacrin. Now, many of you may have heard of Tacrin, some of you may have not, and part of the reason is it's been taken off the market. It had a very serious side effect affecting the liver. But subsequent to that, we had the release of the so-called second-generation cholinesterase inhibitors. And these are medications like donepezil, galantamine, and rivastigmine. These are known by the trade names Aricept, Remenil, and Exelon, but we have over 15 years of experience prescribing these medications, and I should mention they are all available as a generic form now. There have been many studies done in randomized clinical trials, in observational studies that have looked at the effectiveness of these drugs and found that they have benefits with regards to cognition, behavior, and function, those symptoms that we talked about just a slide ago in terms of important targets. By 2005, we had the release of another medication known as memantine, and this is the representative of that second group, the NMDA receptor antagonist. And I'm going to explain how each of these different types of group work. The only other update that I have to share is from 2007, where the rivastigmine transdermal patch became available. The patch is not superior to the oral form of the medication in terms of effectiveness, but it does give your clinician another option in terms of offering a mode of administrating the drug if this is the best way to give the medication to the person that they're treating. But I'm just going to finish off describing how these medications work so we all understand what they're trying to accomplish. So think back to those brain cells that I showed you earlier. There are literally billions of brain cells within everyone's brain. And within these brain cells, there's connections. These dendrites, these little arms and fingers that shoot out from the brain cells interact with each other. And the way they do that is to pass chemicals along from one to the next in order to transmit that message. It was recognized early on that in Alzheimer's disease, there's a relative lack of acetylcholine. That is a brain chemical, which is helpful in memory and other cognitive function. The issue, of course, is how can we boost that chemical up? How can we help the brain when it's struggling? And this is part of how cholinesterase inhibitors work. We can't give acetylcholine directly. It would be too toxic to one's body in other areas. So instead, it has to be approached in a slightly different way. Acetylcholinesterase is an enzyme that breaks down acetylcholine. The body is very efficient. It likes to recycle what it doesn't use. So this enzyme functions normally to gather up what's not used and recycle it. The problem is that if you have degeneration in your brain cells, this chemical is not abundant. It's actually reduced in amount. So if we can actually inhibit the enzyme by slowing it down, we effectively will prolong the duration of action that acetylcholine that is existing can have on the brain. Now, I grant you that that's a bit of a simplification. There are differences amongst the cholinesterase inhibitors, which will prompt your clinician and prescriber to make decisions about what's right for the person that they're treating. But having said that, sharing this common mechanism of action, the cholinesterase inhibitors do offer an option in terms of trying to boost up that chemical level and trying to treat the symptoms associated with the changes that are going on in the brain. Now, one of the important things to note is that we always start at a low dose to avoid side effects. We need to monitor and see how a person's doing. Usually after a month, the dose will be increased to the target dose if tolerated. And then we need to observe. We need enough time to see if the symptoms are actually responding. But remember, these are not disease-modifying treatments. Essentially, if the brain changes are going on in the background, there will be changes over time. And that's not a failure of the medication so much as a reflection of the fact that we're not halting the process, but we're simply trying to boost up the brain for a longer period of time. I'm going to end off by talking about NMDA receptor antagonists because some of you may be a little bit less familiar with this drug. Now, contrast acetylcholine to this chemical, which is called glutamate. In the same way, glutamate helps communication within cells. But glutamate is necessary at some level, but when it comes too high, it becomes toxic. And what happens is that as the disease progresses, we think because of inflammation and activation of certain cells, glutamate levels start to rise. If we can give a medication that helps to block the effects of glutamate from becoming too overactive, this is where medications like memantine may have some role to play. Now, to be fair, memantine is usually most effective in more of the moderate to severe stages of the dementia, but it does represent a slightly different approach compared to the cholinesterase inhibitors, and that's why sometimes you'll see the combination of the two classes of medications used together. The medication, as always, is just like with cholinesterase inhibitors, started low and titrated upwards as a person tolerates it. And one important factor to, of course, consider is all along the way considering and thinking about the potential for side effects. And as many of you know, the medications can have potential common side effects, but medications can also have more rarer, serious side effects as well, which is why a thorough discussion and communication about what to watch out for and what to do in the event that a problem is encountered is a very important thing to start off with your discussion. But ultimately, I can say that these medications have modest effectiveness in terms of treating symptoms, which is actually not a bad thing considering that if you don't treat, we do know that the disease does progress over time. It doesn't work for everybody, but for the right person, it can make a real big difference in terms of, if not improving symptoms, helping to address those symptoms to reduce their impact. Ultimately, again, just coming back to the point of making sure that along the way you're reassessing for a benefit and looking for side effects. So I think that brings me to the end of the time that I have with you today. As I said, I really look forward to any questions that you might have. We've taken a look at a little bit of what the past has shown us. We've had a chance to look at what the present offers us. And I do know that Dr. Shung is going to give us a very tantalizing view in terms of what is close on the horizon. Thank you very much.
Thank you very much. Now we're going to hear from Dr. Shung, as Dr. Lee mentioned, and he's going to talk to you about update on clinical research, and the question is, are we close to a cure? And keep in mind that diagram that you've seen twice now. Will we be looking in the area before people have symptoms, early symptoms, or later? And I think this is the particular challenge that we are now facing, as was implied earlier, about trying to cure this disease, identify it before it starts or as it's starting. Dr. Shung.
Thank you very much. Can you hear me? Because my voice is not very loud. I have to have this special microphone. You can hear me. Okay, good. So I'm continuing on after Dr. Lee's discussion, and I guess I'm actually a transition because Dr. Cashman will also tell us more about recent research on how different methods to potentially treat Alzheimer's disease. But I will focus on what is happening today, and this is just a very quick search on the clinicaltrials.government website on Wednesday night when I was checking this. There has been about 1,500 clinical studies happening in the last 15 to 20 years. And currently, there's still about 391 that are currently recruiting. About 800 of them has already been completed. Some of them are still ongoing, and we don't have the results yet. So there are actually lots of things going on trying to understand how to treat Alzheimer's disease. And within our clinic at UBC, these are the list of studies that are going on that involves humans. So we're not talking about other genetic studies or other biomarkers and lab studies. So these are all the clinical studies that requires human participation. And there are all these things that are going on. I won't have time to go through all of them, but this is just the giving you the breadth of the type of studies that we are currently conducting to try and understand dementia and Alzheimer's disease. And Dr. Feldman already mentioned some of them are pharmaceutical and involve a medication, but some of them are not purely about a medication. We have completed a study on music therapy, which I don't have time to go into, and Dr. Louis Ambrose, who will be talking, also studying about how exercise and cognitive training are helping people. But I will go into the treatment part. And this picture has come up a few times, and you will see it once more, that Dr. Alzheimer's have discovered his disease, the disease that's named after him, when he used this special stain, silver stain, about 100 years ago, and he identified that these kind of fuzzy dark things are plaques. And then within the nerve cells, there are some unusual neurons, the nerve cells inside, they are stained black with these silver stains, and he called them tangles. So 100 years later, we're still focusing on understanding exactly what these plaques and tangles are, and has led to two major hypotheses, the amyloid and the tau hypothesis. There's a strong proponent for the amyloid hypothesis because thus far, most of the early onset Alzheimer's disease with a genetic cause have identified genes that leads to excessive production of amyloid. And those are the APP mutations, the PS1 and PS2 mutations. They all lead to excessive amyloid. And what is this amyloid? So normally, there are this APP, which stands for amyloid precursor protein, because we don't really know what this protein does yet, other than it's a precursor for amyloid. It sits on the cell membrane, so this layer is the cell membrane, and normally is metabolized. So this protein is recycled in the body many times. You produce it, and then you break it down. There's a non-amyloidogenic pathway to break it down. It's called the alpha secretase. And if you cut it right in between where it sits in the membrane, then you're fine. There's no amyloid production. But when you cleave it in the other two directions by this beta and gamma secretase, so these are the different enzymes, they will cut it in between. So this little red strip here is the amyloid protein that is cleaved off and is released into outside the cell. When you have a lot of these amyloid protein floating around, they tend to clump together. And it can become an oligomer, which is a word that when a few of them clump together, and when many of them clump together, it becomes a plaque. And there is very strong scientific evidence suggesting that it is at this stage between the soluble and the oligomeric stage, these clumping together is very toxic to the cells. So a lot of the current advances in the therapeutic is to try and look for ways to decrease these amyloid protein. So one of the clinical trials that we have conducted is to focus on this enzyme, the beta secretase, also called beta amyloid converting enzyme, so the BACE inhibitor. So if we can stop this process, maybe we can decrease the amyloid. And another way is to bind these little peptides, the beta amyloid peptide, is to use a monoclonal antibody. So these are immune-based therapy, and they can be developed to be highly specific. If you bind them, maybe if you can remove these peptide, then you would decrease the chance of having more of the amyloid clumping together to form the plaques. Then there is also the other abnormality in the brain called tau. And what is tau? So this cartoon is showing a nerve cell. A neuron has a body, and the axon is the long part of the nerve cells that extends from one area to another, so that cell can communicate with each other. Within this, the axon, there are microtubules, and you can think of them kind of like train tracks. And these microtubules are important in sending nutrients up and down the cell body. Within these train tracks, this is the tau molecule. So tau molecules are kind of like the screws on the train tracks in order to stabilize these train tracks so that you can have the microtubules performing their job. The tau molecules are sticking onto the surface of the microtubules to stabilize it. When there are problems with the tau, they're released from the microtubules and they clump together and they form these paired helical filaments that eventually become the tangles, the tau tangles. And the tau tangles also appear to be toxic. So if you remove all the screws on the train track, then this train track is not going to hold together. Then they fall apart and the nutrients cannot be stable and sent back and forth inside the nerve cells, and then the nerve cells would die. So a number of different leads is now working on the tau hypothesis, and maybe if we can stop the tau accumulation, maybe we can stop the disease. The other camp on that is proposing the tau hypothesis is that when there's a genetic mutation in tau, it also causes a form of neurodegenerative disease, not Alzheimer's, but a form of frontotemporal dementia that has tau accumulation. And tau is also involved in a number of different degenerative diseases, like Pick's disease, which mostly have tau deposits rather than amyloid, and other diseases like progressive supranuclear palsy and cortical basal degeneration. These are also different diseases that mostly has tau accumulation. So the tau theorists propose that maybe tau is more of a common denominator to some of the different neurodegenerative disease. In the last 5 years or so, actually a little bit longer on the genetic clues, we know that by studying the genes that are involved in the cause of Alzheimer's disease, we can actually find potential ways to treat it and find new targets. And in the large-scale genetic association studies in the last few years, a number of new targets has been identified. ApoE has been around the longest and is related to how fat and cholesterol metabolism goes on in the brain. And our colleague, Dr. Wellington, has done a lot of work looking at how cholesterol is involved in amyloid production. Then there are some newer targets which are related to membrane trafficking within the organelle. So this is a model of a cell. A cell is kind of complex, and that's a PhD thesis, just trying to understand how a cell is working. But within the recent genetic studies, we found a number of genes that are involved in how organelles are being moved around and how these proteins are processed within the cells. And it's now pointing that a number of genes are involved in that pathway are important in causing Alzheimer's. And another area that the genes point to is actually the inflammatory response and the immune pathway. The immune system has been proposed, and inflammation has been proposed to be involved in the cause of Alzheimer's for a number of years. And now the recent genes also pointing that perhaps inflammation and immune pathways are involved as well. And Dr. Lee previously showed a complex diagram showing how amyloid and tau are interacting together. And we now have some recent studies suggesting that they actually work together to cause the disease. Again, I don't expect you to all understand this, but this cartoon is a recent proposed hypothesis and summary of what we know of today. So these red globs are the amyloid plaques. They are formed by these A-beta amyloid and these beta amyloid floating around interact with a number of different molecules, and they lead to a toxicity. They can act in many different ways. It can act on this NMDA receptor, which Dr. Lee also showed because it's related to memantine. But the NMDA receptors causes calcium to flux into the cell. And when there's too much calcium, it causes the reaction to go haywire. And these other blue stripes are the tau. When you have too much calcium, they get phosphorylated. And we know that getting the tau phosphorylated is one step towards the toxicity. There are different ways that amyloid can cause tau to be phosphorylated. And there's recently a study showing that an enzyme called a Fin kinase, which Dr. Nygaard and their group in Yale have been involved in studying this enzyme. They promote the interaction between amyloid and tau and leads to toxicity. So there are many new pathways based on all these molecular studies suggesting that if we target this enzyme, maybe we can also slow down the disease. So now moving back to what's been happening at UBC, there are actually hundreds of studies going on outside of UBC, which I don't have time to go into today, but I will just focus in some of the studies that has happened at UBC and what has happened, because a lot of the audience, maybe your family, are participants in the study. Unfortunately, most of them have been negative or really inconclusive. So some of the studies on the BACE inhibitor have been negative. Although when we look back at the results of these studies, we are now learning why they could be negative. The one molecule that Eli Lilly made actually causes worsening in the treated group compared to the placebo group. And it was because now they know that that molecule is not very specific. So they bind to the BACE inhibitor a bit, but it also bind to some other enzymes that are causing toxicity. And that trial has to be terminated early because it was causing more problems in the treated patients. In another molecule that was focusing on the BACE inhibitor by a different company, that also was negative. In that one, we don't see a lot of toxicity, but in the biomarker study, so in the subgroup analysis, they realized that the molecule that they have don't really get into the brain. They do get into the bloodstream, but if it doesn't act inside the brain, maybe it's not actually causing the beneficial effects. So that one has not a lot of side effects, but it didn't do any better than the placebo group. So some of the monoclonal antibodies was trying to bind the amyloid beta to try to remove it from the body. Another study that we have conducted at UBC using the ponesimab by Pfizer, which binds a molecule that is A-beta 40. That one is also negative. It's safe, there was no side effects, and both groups actually tolerated the treatment well, but there is really no change in the outcome. In the other studies, it's mostly negative, but there's a silver lining because in the bapineuzumab, when they look at the overall outcome, the whole group was not any better compared to the placebo. But in the subgroup analysis, those people who carry the ApoE4 gene seems to be doing better, and also those who are at the milder stage seems to be doing better. So this drug is not completely out, and they're trying to do further studies and see if it's worthwhile to do another clinical trial. The solanezumab and the crenezumab recently has been released, and also the overall clinical outcome looking at Alzheimer's patients in the treated versus the untreated group is negative. But again, when they look at the subgroup analysis, perhaps those that are treated early in the milder stage seem to have a slight benefit. And they're now looking into perhaps refining the clinical trial to move on to the next phase. There are other ongoing trials at UBC focusing on tau aggregation. We have completed recruitment, but it's still ongoing. And the crenezumab, this medication is now going on to open label extension. So they are now trying to follow up people longer, putting everyone on treatment and see if there's a benefit. Now, I won't go into the details of all the different studies, but there are some upcoming studies, including the FIN kinase that Dr. Nygaard will be leading. That will try and see whether blocking the FIN kinase will actually help to slow down the disease. And then there's a newer BACE inhibitor that is much more specific that hopefully will not have the side effects observed in the other studies and will work inside the brain much better. But I will go on to two studies that we are actively recruiting. One of them is the DIAN study, that is the autosomal dominant Alzheimer's disease network treatment. This one is focusing on people who in a family who have early onset Alzheimer's disease and are known to have a genetic mutation. A lot of the mouse model that have been studying how amyloid is treated is to use those mouse models. And those mouse models, in fact, get their gene from these patients. They take a gene and then put them into an animal, and the animal is that model. And a lot of the preclinical studies seem to work in the mouse, and if you're going to try it in a human, so this is probably the human population that would be most equivalent, and perhaps that will be helpful. Another study that is a little controversial, but as Dr. Nygaard has pointed to, is that amyloid can accumulate in the brain many years before the onset of the disease. And if we can actually try and identify the patient at the earlier phase using a PET scan, maybe treating those patients in the earliest phase will be much better than treating when the patient already have the disease. So in this study, we're recruiting patients over 65, and we will screen them with amyloid PET scan. And for those people who are positive, they will be randomized to receive a treatment and see whether that helps to prevent the onset of Alzheimer's. I will not have time to discuss that in more details, but I will just summarize that from here onwards, Unfortunately, most of the recent studies have not been successful, but there are many new promising leads that it's not stopping us from trying more, and there are new ways that we're looking at to treat the disease. And even the negative trials give us a lot of information about how to treat the disease. One possibility is that maybe when we use these treatment, we are treating it a little too late. And going back to the train analogy, if you think of a disease that actually initiates and then starts going, and the amyloid and the tau starts clumping together, when the train is moving along, it takes a lot of energy and a lot of strength to actually stop the train engine from moving forward. But if you treat the disease when the train is only starting before it goes into full speed, maybe it's easier to stop it at that point. And another way is that to think about is that actually Alzheimer's disease has many different mechanisms. So it may take multiple treatments and multiple targets to find a treatment. And the analogy is like the HIV treatment. When we use one medication for the HIV virus, it's not very effective. It slows it down a little bit, but then the virus still keeps on replicating. But if you use 3 or 4 different drugs that work in different pathways, maybe that's what is needed to stop Alzheimer's disease as well. One thing I did not have time to go into is that dementia has multiple pathology. Alzheimer's disease is the most common pathology, which has the amyloid and plaques and tangles. But there are other diseases, including vascular disease, Lewy body disease that causes Parkinson's. Those type of disease can also coexist together. And without good biomarkers to measure these different pathology, it's very hard to understand the mixed pathology. So biomarkers are essential for us to understand the disease and will help us move the field forward tremendously. And I also have to emphasize that while we're studying the treatment of medications, there are other things that we can do without a lot of medications. For instance, just modifying the risk factors. We know that midlife obesity, high cholesterol, high blood pressure, diabetes, high glucose, those are all risk factors for dementia. And perhaps if we modify those risk factors, we can also slow down the disease in dementia. So my concluding remark is that we need everybody's help, including all the patients and their families, to help us with the research to move this forward. Thank you.
Thank you very much, Robin. I'm like Jack Layton. I have my cane in case people are over time. But I think we'll probably use a bit of time into the question period. And remember, Dr. Lee showed you that slide with the cartoon with all the actions and directions and so on. And the top of it was summarized by saying it was complicated. And Dr. Shung has shown us, yes, it's complicated, but we're really trying to understand what those little pieces mean. And our next speaker, Dr. Neil Cashman, has an interest in protein folding. So you're still at the cellular level and at the biomedical level in trying to understand this. And I am very pleased to welcome Dr. Cashman, who's not wearing a cast today, as he was the last time I spoke with him about his exciting research, and particularly interested in the immuno aspects, and hopefully some of that will come up in your presentation.
You still got your cane though, huh? Okay, I would also very much like to thank the inviters, the organizers, and that would include Dr. Feldman and Dr. Nygaard. Thank you very much for allowing me to speak here, and hopefully I'll make some of you interested and others laugh, and it's all good. In the laughing category, I'm the Canada Research Chair in Neurodegeneration and Protein Misfolding Diseases. So my lovely wife, Rosie, says, that's too long. Let's shorten it to your misfolding chair. So I want to disclose that I've actually started a couple of Canadian biotech companies, and I have provided technology licensed by Biogen in the States and CanGene Emergent Corporation in Canada in the States, and I'm also on the scientific advisory board of Prothena Biosciences. So I really don't need to put up this slide, but I just want to comment, as tragic as Alzheimer's is for the people that suffer from it, it's also tragic for families, it's also tragic for communities, and it's also tragic for countries. There's a very cogent argument that can be made that the Western world is going to go bust trying to fund the care of people with Alzheimer's, which is expected to increase tenfold in a generation. There's an interesting statistic on this slide that in the U.S., it costs currently $200 billion a year to support this group of patients and their families. If we could just delay Alzheimer's by 5 years, the onset of Alzheimer's, it would save about $50 billion in the U.S. medical budget and $5 billion here, even in little tiny Canada. So I will talk about protein misfolding. I will kind of switch from what I'd like to call, cognitive impairment to cognitive exuberance. So I will try to pull you along. If you have any questions, I would really like to hear them. There will not be an exit questionnaire, but these are some interesting, although kind of strange and new ideas. I think we all learn in high school that a protein is a string of amino acids, and those amino acids can have very different properties. Some are water-loving, they're called hydrophilic, and others hate to be in water, those are called hydrophobic. But this chain of amino acids only acquires its function as a protein when it's properly folded into a specific three-dimensional shape. So what are the keys to this proper three-dimensional shape? Well, there are helper proteins that help other proteins fold, but the most important thing is from the sequence of amino acids. So the hydrophobic amino acids, which hate to be exposed to water, are all clustered in the middle, whereas the amino acids that have an electrical charge or even a partial electrical charge, they like to be exposed to water. Those are on the outside of a protein. So if you think of the protein as a ball, the hydrophobic interior is the place for the amino acids which hate water, and the hydrophilic exterior or surface is the place for amino acids that actually like to be in water. We used to think that that was the end. Proteins would fragment or get old and get chewed up and released and reused as their amino acids. But it's the advent of something called the prion hypothesis back in the early 80s that has shown us a new way that proteins can operate. And that is a kind of propagated protein misfolding. I don't know how many of you know about the prion diseases, but one of them is mad cow disease, and that, of course, had a big socioeconomic impact on Canada. This is a protein-based neurodegenerative infectious disease. So when prions, misfolded prion protein, come in contact with normally folded prion protein, that protein becomes refolded into more of the abnormal infectious form. So this is a pretty rare disease, despite the fact that it has a huge socioeconomic impact. But over the last 10 or 15 years or so, people have been finding that this prion idea can apply to other neurodegenerative diseases. And we in the lab have been focusing on the application of this idea to Alzheimer's disease. We've also been focusing on this idea in amyotrophic lateral sclerosis. Others are focusing on this idea as a treatment target for Parkinson's disease. Others have done great work in the propagated protein misfolding in Alzheimer's and in ALS. But it's a new way to look at these progressive neurological diseases that seem to spread from one region of the brain to another. It's not only a new way to think about these diseases, it's a new way to identify treatment targets and also biomarkers of the disease, which are misfolded proteins. So how can I stand in front of you and say that this non-infectious disease, Alzheimer's, has a prion-like component? It turns out that the idea that Alzheimer's may spread from cell to cell, from region to region in the brain, that also dates back to the 1980s. Heiko Brock and his colleagues were able to demonstrate that tau abnormalities started in the hippocampus, the part of the brain concerned with memory, and spread through the brain, especially the cortex that's involved in other aspects of thinking. But this was kind of observational that, it seems to start somewhere and spread somewhere else. This idea, the prion-like hypothesis of Alzheimer's disease, only really had experimental footing in a series of papers that started to be published back in the year 2000. Work by Larry Walker and Matthias Euchre showed that you could actually inject some Alzheimer's brain homogenate into the brain of a mouse and trigger or seed a spreading amyloidosis. Here's a mouse that's been injected with some Alzheimer's brain homogenate that shows staining for amyloid. So it's gone from the point of injection and it's spread through the hippocampus. Later studies show that it spreads to even more regions of the mouse brain. So what is the seed? What is the thing that triggers this propagated protein misfolding of A-beta? It also turns out over the last few years that it's become clear that it's not the fibrils, it's not the plaques, it's not tau or neurofibrillary tangles, it's little clumps of A-beta called oligomers, and this was referred to in Dr. Sung's talk. So these little clumps seem to be able to seed their propagation. They float from one part of the brain to another, and they act as kind of like crystallization foci to make amyloid appear and spread in the brain. Now this is very, very interesting because it turns out that the seeds not only are triggering this, spreading amyloidosis, but they're responsible for the toxicity of A-beta. So it's not the precursor protein, it's not the monomers, the individual strands of A-beta, it's not when A-beta forms into fibrils or plaques. It's this intermediate small clump called oligomers that are killing nerve cells and actually causing synapses to dysfunction. So here's where we stepped in. I'll run through this quickly, but what we did was to look at the structure of A-beta fibrils, and we found something that was exceedingly strange from our understanding of how proteins fold. Remember, I told you that the charge is on the outside and the hydrophobic amino acids are on the inside. Here is what's called salt bridge between two charged amino acids in the interior of A-beta fibrils. Well, that doesn't make sense from a protein folding point of view, but it certainly makes sense from the standpoint of stability of A-beta fibrils. They kind of form and they stay. They're like a bump on a log. They don't interact with cells and other molecules or tissues. So that's kind of like the safe garbage dump. So it did make sense that this charge was buried that would make the fibrils very stable and insoluble, in other words, not liking water. But when you think about a structure that has solubility, that is small and unstable and rapidly changing into other forms, in other words, the oligomers, what we thought is we should expose these charged amino acids on the surface of a synthetic peptide, which could perhaps mimic A-beta oligomers. So we raised antibodies against this mimic. We found that the antibodies did not react with fibrils, but did react with a water extract of brain, and did react with spinal fluid only in Alzheimer's disease, not in age-matched controls. We also found, and I won't go into great detail about this, but that our antibody was able to block the toxicity of A-beta oligomers. One of the important features of A-beta oligomers is that they're responsible for toxicity. And incredibly, we were able to show, compared to a control antibody, our antibody was able to block the formation of A-beta plaques. So we had what seemed to be an antibody that could not only recognize A-beta oligomers, but could block their toxicity and block their capacity to trigger this spreading amyloidosis in an experimental model. Now, Dr. Sung didn't mention this, but one big problem, at least a theoretical problem, with antibody therapeutics for Alzheimer's disease, for ALS, for Parkinson's, is the protection that the brain has from large concentrations of antibodies or large molecules. So there's a block, something called a blood-brain barrier, that keeps most antibodies from getting into the brain. So we were concerned about this with our antibody, but we found in mice we were able to reduce the concentration of oligomers in the brain and in the spinal fluid. So this is a good indicator that our antibody at least gets into the brain of mice. So I just want to close by saying that this idea of propagated protein misfolding, I've told you, has applications in Parkinson's disease, in ALS, in Alzheimer's disease. There's a whole universe of proteins out there that can participate in this process, and it might be a road to identifying new immunologic targets, new therapeutic targets for these untreatable disorders. And let me just walk you through. Well, it's not allowing me to. There we go. So I just want to show you this in such a simple way that even I can understand it. A protein in a cell gets misfolded, it convinces its neighbors to misfold, it can travel from cell to cell and induce that cell's proteins to misfold. So both cells die. But here we have the same situation in the presence of an antibody or a vaccine against the target, and the nerve cell is protected. So that's the basis of what we're trying to do in the lab for neurodegenerative and psychiatric diseases. There's the team. The old guy in the middle, of course, is me. The guy in the back here, that's Abrima Gibbs. I don't know if he's here, but he has a poster out there. Some really beautiful science on our antibody discovery. And I want to thank my collaborators, especially my UBC collaborators, and my sources of funding. So thank you very much for your attention.
Thank you very much. And I think that I very much appreciated that last slide. And I would like to ask our speakers to come up. And Dr. Lee, would you mind bringing a chair with yourself? And I have some questions from the audience. And I am going to suggest that we just move the program along and finish at 12:30 today, because otherwise we have no time for questions. The first question is for Dr. Shung. Does music therapy help?
Sorry?
Does music therapy help? You alluded to that on your slide.
For some patients, yes. That's a short
Thank
answer.
you.
But
It's a revelation.
But to discuss how it helps, it'll take more time. But it mostly helps with the behavioral symptoms. It doesn't help the memory, but it helps to calm down their behavior.
Do you want to just describe what the music therapy intervention is, just so people have some idea of what that is?
Okay, so the music therapy intervention that we have is that we have a specific music therapist and scheduled music therapy for our patients over a 12-week period. And during those 12 weeks, the patient and the family member may want to stay or they don't have to, but they bring the patient in once a week for about 1 hour for the 12 weeks duration. During that time, the music therapist will actually take a music history. They ask the patient what type of music they like, and then they will play different type of music that the patients like, and try to get them to interact, maybe singing or dancing or just humming the sounds out. And we focus specifically in patients who have some behavioral abnormality, because we felt that if patients who are doing just fine, they probably don't need it. So it was a very specific population that we focused on.
Thank you very much. The next question is for Dr. Nygaard, and some of this is related to the intrigue of having a PET scan, and yes or no, and should you have it ahead of time. And you have suggested that scanning is not fully available, but stay tuned. And could you elaborate what this means in terms of what could happen for individuals? And they also ask, would fundraising help?
Well, I'm glad this was brought up. The significant roadblock at the moment is that some of these technologies are not available in British Columbia, and in fact not available in the world because they're quite expensive. And we are working on two fronts. One is to develop biomarkers that are more affordable, that could be more easily implemented. And the other is to, when there is a therapy, we hope there will be a therapy developed in the next decade or two. At least that's what we all are working towards. Once there is a therapy available, then imaging is likely to become more widely available as well. So that is the roadblock, and we're working with the regulatory authorities and others to see whether we can make more imaging available for patients and their families.
I'd like just one. one additional comment, which is important. The question is, might donations be helpful? And it's just important to underscore that translating research from the lab to the clinic often falls in a spot that nobody wants to pay for. And so the answer really is yes. Donations are very potentially helpful because they will give us bridge funding by which we can take imaging and begin to study people in a real life situation to accrue the evidence that then government might be willing to pay for. So there is a very critical bridge step that is hard to get money for, to which donations would be helpful.
Underlined. Thank you. For Dr. Lee, two questions. One is related to, do NSAIDs help? Or these are non-steroidal anti-inflammatories. Do they help or do they harm? And the second question is comment on a recent finding from Health Canada about serious side effects, I presume from Aricept, rhabdomyolysis, or neuroleptic malignant syndrome.
Okay, to answer that first question, I guess first in order, I think some of the preliminary research that this even dates back for a number of years ago suggested that anti-inflammatories, particularly NSAIDs, may have some positive role to play in either prevention or perhaps treatment. I think as the question highlights, there's that balance which has to be felt, which is really the risks of using these medications. NSAIDs are commonly available, some of them without prescriptions, but the problem is about the side effects, high blood pressure, kidney problems and such. I think as best that I can say right now, it's not definitive in terms of saying specifically that people should go on NSAIDs, particularly to treat symptoms related to Alzheimer's disease. I think this is still an area which is being researched. I do know that a lot of the trials that have been done in a more scientific manner have not really proven a definitive benefit. So as best as I can say, I think it's an area that deserves further exploration. But as far as going to recommend that to our patients, I would certainly hesitate at that. The second part, which is actually a very interesting thing, somebody is obviously very up on the news. This warning from Health Canada was released actually on January 21st, so really only about a week and a half ago. And it was really about those two entities, rhabdomyolysis, which is muscle breakdown, and a second consideration, which is neuroleptic malignant syndrome, a very rare but potentially fatal disorder. Now, the thing that I just want to comment on is this warning came about because of Health Canada responding to the fact that one case in Canada had been reported of rhabdomyolysis. So of the many prescriptions that are given for donepezil, which is Aricept, and remember that this is the one medication this warning was released for, not the other cholinesterase inhibitors yet. Based on this one case and their review of the international data, which said that across the world there was about 88 cases reported of rhabdomyolysis and about 69, I think, of neuroleptic malignant syndrome. 3 of them resulting in fatalities, I think, for rhabdo and 9 for neuroleptic malignant syndrome. The issue is, of course, they had to issue this warning, and I think very appropriately so. But if we take a look at those numbers and think about how rare that is in occurrence relative to how many people are taking this medication, I just have to put that caveat that says that before everybody panics and goes off of the medication, I think we really have to have a careful consideration about what the actual warning means. Final thing I'll say is that most of the international cases actually came out of Japan, and of those, many of those people were also on other medications that could put them at risk for these types of reactions, like antipsychotic medications or other types of medications like that. So I guess the best thing to do is, of course, if you have a concern, I would encourage you to discuss that with your clinician. All concerns are valid, and there's no reason to believe that if you really feel like that risk is too prohibitory in terms of considering these medications, that's absolutely something to talk about. But I think that it is that response that I would give to anyone who is asking me that question, to say, balance that against what you consider to be the potential benefits of the medication and see whether or not it's appropriate to continue.
And rhabdomyolysis is?
It's muscle breakdown. So it's a very rare reaction too as well, but when the muscle breaks down, it obviously is causing damage to not only the muscles, but if it builds up because it's not filtered by the kidneys properly, it can result in kidney failure.
Thank you very much. And this is a question for Dr. Cashman. questioning whether there's a viral component to the promulgation of folding of a protein.
So this is so the answer is no, or at least probably not. The prion world, the mad cow disease, Creutzfeldt-Jakob disease, that had been engaged in a debate for almost 50 years about what sort of virus could be infecting people or animals. So it was the prion hypothesis of Stanley Prusner, which ultimately garnered a Nobel Prize in 1997, that said that you don't need a virus, you don't need DNA or RNA. What you need is a protein that's misfolded that can trigger the misfolding of another protein. So this kind of propagated protein misfolding is a form of infectivity which is is unprecedented. No virus, no bacteria, no fungus, nothing. It's a new way of thinking about things that has more akin to crystallization than it does to actual life. And as I said in my talk, we've now figured out that there's a prion-like component for non-infectious neurodegenerative diseases like Alzheimer's, Parkinson's, and ALS.
Now, a question for Dr. Shung. You mentioned that too much calcium may be involved with the disease progression, and many people have been taking supplemental calcium for osteoporosis prevention. Is this good, or is this contributed, or is this a factor?
So that's a good question. I want to clarify that the picture I show is the intracellular calcium that is bad. It's not calcium by itself. So there are lots of people who have low calcium for bone problem. It's fine to take calcium supplements. When the cell is injured or when the NMDA receptor is triggered abnormally, then excessive calcium will go into the cell. And that is the problem. So it's not this calcium that is floating around that is the problem. It's when excessive calcium leaks into the cell. That's the problem. So it's fine to take calcium supplements.
Thank you. Now, there's one question here. How can my wife get referred to the program? Fill out one of the cards and take it up to the information booth. That's pretty straightforward. Or your family doctor can make a referral to the clinic. At this point, I think we need to conclude because we have a coffee break, and we'd like you back here in half an hour. And our program has just moved 15 minutes forward. So don't forget, we need everybody, there's posters outside in the coffee area, and the people that did the posters will be around to talk to you about them. As well, the washrooms are just outside the door to the left. And if you have any questions, talk to any one of us. Thank you.
Test? Test?
I'm just going to shut off.
Hello? If I could have your attention, please, and have everybody get to their seats as soon as possible. We'd like to get the second segment underway. Well, I'm very pleased to have you back here for our second round of educational talks. I'm Dr. Dean Fody. I'm a behavioral neurologist working at the clinic for a number of years now. I'm very pleased to bring on the second half, which I noticed happens to be the gender flip. So we had all male presenters, now we've gone to all female. So we are sure to stay on time this half. So it is my great pleasure to introduce the next speaker, Cheryl Wellington. She's a professor of pathology and laboratory medicine. She is one of the most energetic, enthusiastic researchers and has really moved forward in great ideas. She's going to discuss the link between Alzheimer's and concussion. Concussion being a traumatic brain injury, and there are very important pathological links and what that might mean for us in the population. Well, please welcome Dr. Wellington.
Well, thank you very much. It is an absolute pleasure to have the opportunity to chat with you today. What I'd like to introduce is the concept that brain injury can be a risk for Alzheimer's disease, but also, as I tell the story, try to leave you with two things. One is why questions about the links between brain injury and Alzheimer's disease actually offer a lot of hope for absolutely innovative new opportunities to pursue. And the second is that I could be in no better environment to pursue these ideas, being in the new Center for Brain Health among the clinicians who absolutely support research like I do, which is more behind the scenes in the basic laboratory. So the first thing that I'd like to say is that traumatic brain injury has been around for as long as humans have been alive. It is the earliest recorded type of injury, and in fact, about 30% of early humans have evidence of skull fracture in their remains. So this type of injury has been along since humans could use anything as a club. We obviously live in a much more civilized society today, but every year in the United States alone, there are 1.7 million new brain injuries every single year. It is an enormous unmet medical need in its own right. And as we understand more about the possible connections between brain injury as a risk factor for Alzheimer's disease or related dementias, the need to understand these connections becomes more and more important. Now, falls and motor vehicle accidents are the greatest causes of traumatic brain injuries. And so that statistic occurs both in the United States and Canada. One thing that's very interesting about traumatic brain injury is that there are two age ranges where it's most common to get a brain injury, and this is what we call the incidence of brain injury. The first peak is in late adolescence and young adulthood, and this is mostly for the young men who are often trying to show off in their snowboarding skills or this or that. But that is the first real peak of age where brain injury occurs. Later on, though, as people get older, falls become another very important source of brain injury in the older population. And when a brain injury occurs in the older population, even the same level of biomechanical force that the brain receives can have more severe consequences. We don't yet understand the differences in how the young brain might respond to the same exact type of mechanical injury as the older brain. And this is something that in my research laboratory we're trying to address. Now, traumatic brain injury is actually a very challenging clinical entity to study. And partly is that there's an incredible diversity of brain injuries. Typically, in the clinic, we classify them as mild, moderate, or severe, depending on the type of verbal responses, et cetera, that a patient will have. But I've heard this definition be challenged as being almost as meaningless to say, to use these descriptors for something like cancer. We don't say somebody has mild cancer or moderate cancer or severe cancer. We say they have lung at this stage. But for brain injury, for example, we don't have more definitive descriptions of how to classify the brain injuries yet. In addition, the majority of brain injuries, about 80% of brain injuries that occur in humans, are mild. They don't cause death. And the most common outcome of a mild brain injury or concussion is complete recovery within 2 to 3 weeks. There are some people that have problems or longer time to recover, but the majority of brain injury cases are mild. So that's good because people don't die from them. But it also leaves us, though, we don't have tissue specimens or biofluids with which to study mild brain injury yet. The majority of the brain tissue samples that we get are from the very severe cases. So these are people who succumbed to the brain injury, but we don't yet have a lot of clinical samples or clinical opportunities to bridge that gap. In a sense, every human being's injury is unique. A brain injury can occur at any age, at any time, in any context. And so this poses a great challenge for us to be able to define how brain injury actually leads, or how some people can recover and some people don't. So what we know so far about the links between brain injury and dementia is that the evidence is fairly strong that moderate to severe traumatic brain injury with loss of consciousness is a risk factor for dementia. How much, you might ask? Well, it's about on par with if you have one copy of the ApoE isoform or if you have diabetes, for example. So it's about a 3-fold increase of risk. We don't know yet a lot about whether mild brain injury with loss of consciousness may be a risk factor. We really don't have a lot of clinical evidence for that. And it's even more challenging for people that might have a concussion without any loss of consciousness at all. There's actually inadequate evidence to suggest a link at this point. Now, I'm sure almost everybody in the room has heard about football players getting a form of dementia. Everybody? Yeah? Oh, yeah, okay. You are incredibly well informed, and good for you. So this is actually a really interesting opportunity. So what happens to these football players, let's put the first caveat on there. The football players who have donated their brains for study, and that's not all of them, it's a small proportion of them, a lot of them have a pathology that we call chronic traumatic encephalopathy. It's a long-term consequence of repeated exposure to mild brain injury. The thing to remember is that these football players have had hundreds and hundreds of concussive types of injuries. So they are representing probably a fairly extreme form of concussion exposure. We do not know, number one, what proportion of football players will go on to develop this disease. There is no standardized study looking at all football players across the board. And number two, we don't know yet whether the results of the football players can be applied to the general population. So these are the types of questions that my group is very interested in studying. One of the reasons that it's really interesting as a potential link to Alzheimer's disease is that the neuropathology has a couple of similarities. So here you're seeing brains. Here's a normal person, and this is a typical Alzheimer's disease person here. The Alzheimer's disease, by definition, has amyloid plaques, so these are the orange dots here, and neurofibrillary tangles, which are the sort of more browny stains here. And here are two examples of specimens from two different football players. And you can see that it's overwhelmingly tau that these players develop. It turns out that about a third of football players that have been examined, and this is true for all different types of brain injury, only about a third also have amyloid deposits at autopsy. Let's think about that for a moment. There is a brain injury. At a certain time later, these people will pass on, and if they have donated their brains, then we can examine what is in their brains at the time of death. But with brain injury, there could be a difference of years, if not decades, between when the injury occurred and when we get the sample. So when we say that only 30% of people with a brain injury have amyloid deposits at the time of death, it gives us about two possibilities. Let's work through those. One is that maybe only 30% actually get amyloid. But another possibility is that maybe some people get amyloid and then they're able to get rid of it so that by the time they come to autopsy, it's no longer there. We don't know which one is the truth. But if there is something about the younger brain that can help get rid of that amyloid that might come up after a brain injury, understanding that might open the doors for absolutely newly innovative ways in which we can maybe rescue that function in the older brain in the context of Alzheimer's disease. So these are the sorts of questions that my group is studying in the research laboratory. And I'll take you through a little bit more of the details about how we might think this occurs. So what happens in a brain injury is that there's usually impact of some sort to the head. And the head will accelerate and decelerate. These are engineering biomechanical terms that really describe force acting on the brain. It kind of moves back and forth in the skull. What happens there is that the nerve cells have a vulnerable part called the axon. It's vulnerable basically because it's skinny. It's like spaghetti. And if it's being waved around, it's going to have shear strain on that axon. And in few cases, it can break, but mostly it's stretched, it's twisted, and this is not a very desirable condition for a nerve cell. What happens after brain injury and a stretched axon is that all of the factors leading to production of the A beta that forms deposits in Alzheimer's disease are made in the acutely injured brain. These are specimens taken from a person who succumbed to brain injury after 10 hours. So only 10 hours after injury did we see enormous blockage of the amyloid precursor protein. This is the parent protein from which A beta is made in these stuck axons. And within 10 hours after injury, we could see amyloid plaques. This was in a patient that would have been too young to have developed these amyloid plaques during aging. So this is some of the evidence that amyloid formation can happen very quickly after a severe brain injury. But we don't yet have a lot of evidence about what might occur after a brain injury and whether the brain has a mechanism to get rid of that amyloid. But if it doesn't, then this might be one of the seeds, one of the links between why a brain injury may increase risk for dementia long-term later. So what can we do to bridge the gap between what we can do clinically in brain injury and what we need to be doing in the research laboratories? So this is where experimental model systems come in. So for the past couple of years, we have been working together with a team of biomechanical engineers to develop an animal model of brain injury that for the first time can reproduce the kinds of biomechanical forces that occur during a concussion. No other group in the world has built what we have built here. The reason that this is important for a couple. Number one, We can't go around behaving like our early human ancestors did. We can't do experimental brain injury studies in people. We need to take in what comes in the emergency room door, and they can be anything. But with experimental models, we can specifically test things like, does amyloid come up and then go back down after brain injury? As well, we can then create a source of tissue from which biomarkers of brain injury can be learned. This is especially important for the mild cases where there's almost no autopsy tissue available. But from animal studies, we can search for markers that we can then test and develop into a blood test or a lumbar puncture test or an imaging test for people with brain injury without needing to have the autopsy tissue. In the looking ahead to the long-term future, we knew from this morning that things like a PET scan for amyloid is not routinely offered yet. But it could be that if we understand more about links, like things like brain injury, maybe it could be in the future that if people have a brain injury, they might be flagged for a PET scan maybe every 5 years or 10 years after an injury, just to make sure that things are okay in their brains. So together with a group of engineers, we have built this new model system that we call Chimera that's really, really exciting. From the neurobiological point of view, our group is very interested in understanding things like amyloid and tau and inflammation after brain injury. But the other advantage is from the engineering side. Even though we lack and will always lack a lot of autopsy tissue from clinical TBI samples, what the engineering field is doing in brain injury are doing studies, for example, where athletes are wearing helmets that have accelerometers in them. So there's a lot of data that are now being collected on the exact kinds of forces the brain experiences during a typical concussion. And the neurologists that are seeing these concussed patients can then inform us about the relationship between the type of brain injury, the severity, the angle of impact, the acceleration that the brain occurred, and what happens to their post-concussive recovery. And then we can learn from those studies, go back in our animal models and learn more, and then bring new information to apply to humans. I'm just going to show you 2 slides from our animal model so you can see how closely we're replicating what happens in human injury. So on the top half, these are samples from different parts of the brain. So this is part of the olfactory system, the nose to the brain. This links, this structure, the corpus callosum, is the sort of a white matter linker between the 2 brain hemispheres and other brain regions here. The important thing to look at is this little beads on a string structure. These are the damaged axons after a brain injury, and they make these swellings that look like beads on a string. This is what we see after human brain injury, and we know that the response of the brain in our model system is very similar to what happens in a human injury. So this is very, very exciting, groundbreaking new work. If we subject a mouse model that's destined to get amyloid deposits to a typical football-like concussion, in 48 hours, we see increased numbers of amyloid deposits. These are these little dots here. This is before the brain injury. 48 hours later, we've increased the amount of deposition of A beta by around 25%. So we're in the middle of those studies now, trying to figure out about how this all works, and does this stick around? Does these amyloids stick around, or do they clear? So I'll wrap up by saying that understanding the long-term consequences of brain injury is a really exciting opportunity, and will require a very integrated research approach using both clinical and preclinical systems. So we are all working toward developing accurate diagnostic and prognostic tools So how can we really diagnose a concussion well, other than just having patients report, I have headaches, I feel dizzy? Is there an actual laboratory test or imaging test that we can develop to be more accurate than subjective tests? How can we use these tests to monitor recovery from after brain injury? And can we use them to flag people who might be having problems recovering normally? We're interested in understanding whether some of the same genetic factors we know increase risk of dementia might also prolong recovery after brain injury. So we're working very closely with people that are in the imaging field using MRI, PET, and other imaging modalities so that we can examine what happens after the brain without needing to get autopsy tissues. But we need to develop these sensitive markers, usually in preclinical systems, test them in humans, and then learn from one another in an iterative basis. There is a large program here at the University of British Columbia that is focused on rehabilitation and neuropsychiatric monitoring of people after brain injury. So these turn out to be very effective in promoting recovery and having us noted of patients who are having problems. And of course, we are looking very much toward developing effective drug and rehabilitation combination treatments for brain injury. So I'm going to wrap up here and thank my two graduate students, Dhananjay Namjoshi, who actually just finished his PhD thesis, and Tom Chang, who's here in the audience. They're the people that have been really working on the system. Peter Krypton and Kurt McInnes are the engineers who really helped us build the system and who will help us extract value from it and apply to both TBI and dementia studies in the future. So with that, I will be happy to answer any, well, I guess we're having a question period later, right? Okay, so thank you for your attention.
Thank you, Cheryl, for that very interesting talk. Lots of potential avenues to link Alzheimer's and concussion research together. As a reminder, you have the question cards in front of you. You can write out questions after each talk and somebody will pick them up. If you need more cards, then ask for them. Our next speaker is Dr. Teresa Liu Ambrose, who's an associate professor in the Department of Physical Therapy. And she's going to talk to us about exercise and how it impacts aging and brain health. Very important topic and dear to my heart, as she is really trying to put some good science behind the motherly advice that walking a lot and exercising is good for your health. So it's my pleasure to invite her up to speak. Thank you.
Thank you.
Step behind me.
Yeah. Thanks, everybody, and it's really my pleasure to be here today. I really hope the forum has been a great start to your weekend and that all of you will get to sort of enjoy the great weather we're expected to have over the next few days. So for today, what I'd like to do really is the next 15 minutes is to share with all of you sort of the latest evidence that we have that would suggest that exercise may be one of the best form of medicine for the brain, and as such that it really is a promising strategy for dementia prevention. So what I like to do is really highlight the key findings in the literature, also share with you some of our own work here done at UBC. And as well, what I like to do, and maybe this is my main goal, is to really convince all of you that the dose we're talking about that may be of benefit in promoting brain health is really feasible for the majority of individuals. So a concept that is critical to understanding why exercise may be essential to maintaining brain health as you age is the concept of neuroplasticity, which refers to the fact that the brain is actually trainable across the entire lifespan. So we all know that in terms of brain development, years 0 to 5 is hugely critical, and as well as the teenage years. In those age ranges, the brain is extremely receptive to the environment you impose to it, and it develops accordingly. But we also now know that throughout the entire lifespan, so even in old age, the brain can change. So what do we mean by that? So specifically using neuroimaging in humans, we can assess and have found that the brain can actually change in both brain structure and its function. So brain connections from different regions can grow stronger, and the brain itself can actually increase in volume. So literally you can change your brain, and that's really essential to understanding why exercise is of benefit. And I suppose we shouldn't be surprised that physical activity is essential for brain health, given that the brain is a highly metabolic organ. It's all of 3 pounds, and I hate to say that I didn't learn that from being in school, but watching Jerry Maguire. That was the first time I learned about that fact, and I thought, cool. Anyways, 3 pounds, but it actually consumes 20% of your body's intake of oxygen, and also blood supply, So it literally, I don't have a good anchor for the mic, so I'm going to just, should have wore pants. So literally, your brain is the best customer for both your heart and your lungs. So you really need a strong heart and healthy lungs. So by maintaining a physically healthy body, you really are providing the most optimal physical environment for your brain. It maintains blood flow. It increases local circulation, what we call growth factors, which really, in lay terms, I would call as brain vitamins. Okay, we're always kind of keen on finding the optimal nutrients or supplement that's good for your brain, but your body actually produces them naturally, and they actually do increase in production when you exercise. And overall, at a systems level, when you are physically active, you do reduce your risk of developing conditions such as diabetes or high blood pressure, and we all now know that those conditions do increase your risk of developing dementia with age. So when we talk about physical activity, today I'm going to focus on types of physical activity because my research really focuses on how can we optimize exercise prescription for brain health. So when we talk about types of exercise, 2 major types are aerobic training, so any type of exercise you do to increase your heart rate, to increase your lung capacity, so running, swimming, and as well as resistance training, which is really primarily aimed at increasing your muscle strength or muscle power. Now, I recognize that many exercises that you do every day probably combines a bit of both, and that's great. But for sort of scientific inquiry, I'm going to sort of artificially separate them as if they're quite distinct. And they are distinct in sort of the physiological targets. I also do want to recognize there's many other forms of physical activity, such as balance training or agility training, which is hugely beneficial for older adults in terms of falls prevention. And as we already heard, falls is a major causal factor for traumatic brain injury, so it is important when we think about healthy age incorporating other types of exercise. But for today, I'm really going to focus on the evidence regarding both aerobic training and resistance training. So just to provide a very brief roadmap of where I'm going to go from here, first I'll talk about studies specifically examining different types of exercise training and its effect on both cognition as well as brain health. And then I will highlight one study to really kind of bring it home in terms of optimal dose and whether or not that, the majority of us can agree that we can uptake that behavior. So first of all, what are the effects of aerobic exercise on both cognition and brain health? So the first study that really examined this particular question was actually published back in 2004. So it's been a while actually in terms of the scientific inquiry looking at the role of exercise on cognition and brain health. So what this study did is basically recruited community-dwelling older adults, so otherwise healthy without a diagnosis of dementia, and randomized them, so by chance put them in a group of stretching or in a group of program whereby they had to walk 3 times per week at a moderate pace, and each session was approximately 60 minutes. They assessed everyone's cognitive performance at the beginning of the study and then also at the end of the study, which is 6 months later. And what they found was that at 6 months, those individuals who were in the walking group actually significantly improved their performance on these cognitive tests. And these tests related to your attention and as well as your ability to make decisions quite quickly. They also were the first to show that the brain actually can alter itself as a result of participating in 3 times per week. So what they did is they acquired data from MRI, where people were doing tasks while they're lying down in the MRI and basically looked at how was the brain functioning. So when we look at these sort of red bulbs on this scan here, is really showing that there is increased activation of blood flow to those areas, demonstrating that those areas of the brain were activating or being recruited to perform the task at hand. And what they showed is that within 6 months, we saw these changes in the brain that indicated that there was increased recruitment or activation in those regions while people were performing the task among those in the walking group. The same group of researchers then most recently published another paper, now a 12-month trial, but again still focused on aerobic training or a walking program that showed that aerobic training could improve memory. So again, similar design. People were measured at baseline or at the start of the study, and then once again 12 months later. Here they found that walking did improve memory performance, and as well, using structural MRI now, so looking at brain volume, they found that walking could increase the hippocampal volume by 2%. So what is the hippocampus? It's a distinct structure in the temporal lobe of your brain that is primarily responsible for memory. For individuals who do have Alzheimer's, if we did scan your brain, the hippocampal would show significant shrinkage or be a lot smaller than what we would expect. So here they actually showed over a 12-month training period that you could actually increase the volume of this structure by 2%. So I guess the question is 2% good or bad? Kind of depends, right? Just like anything else. So it's RRSP season, so 2% on your return wouldn't be great. But if you're renewing your mortgage with a prime dropping, 2% would be fabulous. Okay? So it depends. We have to put it in context. So within context, 2% increase in hippocampal volume is equating to reversing your brain age literally by up to 2 years as well. So that's a pretty good return. You put 1 year's worth of work into yourself and you could reverse your brain age by 2 years. And the exciting thing is that there's now emerging evidence to suggest that exercise, and specifically aerobic training, can still be of benefit for older adults who are now at risk for dementia. So the first 2 studies I just talked about were among otherwise healthy older adults without a prior diagnosis of dementia or having any evidence of decline. Now there are studies being done to look at those individuals who are at greater risk, such as those with mild cognitive impairment. So in terms of those individuals with mild cognitive impairment, if you did assess them, they would have some decline in their cognitive performance, and they may express that they are concerned about their cognition. So they may say, I find last 6 months I'm really having a hard time remembering things or making plans or making decisions. And then when we objectively measure them, we would see these deficits. Yet they're still functioning quite well. So they're still living in their own homes and managing generally pretty well. But there's still some deficits that's occurring. And we know statistically that they are at greater risk for developing dementia. And so actually in our lab in 2014, we actually did show that aerobic training done twice a week could also be of benefit for individuals with MCI in terms of improving memory and also improving the hippocampal volume. Furthermore, we just recently completed another randomized controlled trial, again among individuals with MCI, but of vascular origin. And again, here we found a 3 times a week walking program was beneficial in improving cognition. So then, what about resistance training? For those of you who have had a strong interest in looking at the role of exercise in brain health, you probably have noticed a lot has been focused on the aerobic aspect. So, walking, running is good for you, increases blood flow, and those are all true. But for whatever reason, there wasn't a lot done in resistance training, certainly not 5 or 6 years ago. However, we do know that resistance training or strength training has utility in healthy aging. We already talked about falls prevention, right? But it's also very beneficial for bone health. And the other perspective I really want to sort of emphasize is that as you age, you lose muscle strength and mass. It's called sarcopenia, okay? It may be more evident in some versus others, but in general, you do tend to lose muscle mass. And when you get weak, you become physically unable to actually be active potentially, right? If you can't walk upstairs, or even if you have difficulty getting out of a chair, it's actually hard to be physically active, And so for me, I think resistance training has a huge role because it almost provides the basis for you to be physically active as you age. So now I like to do is highlight some of the key findings relating to what are the effects of resistance training on both cognition and brain health. So one of the first studies that was published that I thought was a really good piece of evidence in regards to the benefit of resistance training on cognition was actually done in 2007 by a group from Brazil. And they looked at 3 times a week of resistance training, both at moderate and high intensity, for 6 months. And this particular study focused on men only. And just very briefly, I don't have a lot of time to explain as to the why, because we don't really know why. But there is some suggestion in the literature to indicate that women may benefit more so from exercise than men when it comes to brain health outcomes. So more recent studies have tried to be a little bit more potentially specific in who they recruit. And so this is one of the studies. So that was one of their arguments as to why they only included men. So for this study, they also did find benefit of strength training on both memory and executive functions. And what we did here locally is to extend that by examining the role of resistance training now in older women. And so this is a study we published back in 2010 and 2011, and then we also had subsequent studies that were published in 2012 and 2014. But the first study that we did do looking at resistance training basically was a 3-arm study whereby we recruited women and we randomized them to 1 of 3 groups: once a week resistance training, twice a week resistance training, or twice a week balance and tone, which really was our comparison group. So I really want to highlight across all these exercise trials I talked about, they actually were controlled, or they were actually being compared to a group that were physically active still. They just weren't participating in, let's say, aerobic training or participating in resistance training. So really, I would say any sort of estimate I'm providing you here is quite conservative. Okay, I hope, does everybody appreciate that? So we're really comparing still to it being an active group per se. So this study was 12-month in duration, and we looked at their cognition at baseline and at 12 months. And so in terms of the training, I already talked about in terms of frequency. In terms of the duration of each session, there were 60 minutes, and our resistance training protocol was progressive, meaning that once we set a base weight for them, we were pretty hard on our participants, or encouraging, so maybe a more positive way of putting it, is that, every 2 weeks we would check up on them to see if they could do more weights with appropriate form, and if they could, we would increase it. So we were always trying to increase the loading as long as it was within their capacity and safety. And again, for the balance and tone, it was also twice a week, 60 minutes, and they actually did do exercises such as very simple balance exercises, a lot of stretching, a lot of core exercises. So as you can see, that particular program still have benefits, but potentially not as much on the cognitive outcomes. And so what do we measure? Obviously cognition. We also used neuroimaging to look at both brain function and brain structure. So in terms of cognition, there's many ways of measuring it. So I'm just going to sort of give an example here. This is what we call the Stroop task. It's a task we use very often in our research studies. The task at hand for an individual is to call out the word. So when you see the word that's presented to you, the instruction is to ignore the written word and instead call out the color in which it's printed in. So for example, this would be green. Keep going. You guys are good, but have you noticed even as you were starting to go down the list, you start faltering a little bit? The first 2, usually people start great, and then they start getting, So what you should have noticed is that you want to just read the word, right? Because that's your automatic response. That's what we've been trained to do since we were 4, right? Read the word. And so here what we're really testing is, how well can you attend to the task, and how well can you sort of basically ignore a conflicting cue and make sort of the appropriate decision given the rules provided to you. So the real task has actually 120 cues, so you can imagine there's some fatigue involved. We basically also record down the time it takes you to complete it, as well as how many errors you make and how many errors you correct as well. So that's just an example of what we do in terms of measuring cognition. And then we also measure your brain using the 3T MRI. So with the MRI, both structure and function could be assessed. So we can look at whether there are silent lesions. Okay, so this is what's showing here is some type of small vessel disease that's affecting the white matter. We can look at volume, and we can also looking at brain function, so blood flow patterns in relation to a task at hand. And so what do we find? So we found that resistance training actually did significantly improve cognition, specifically the ability to pay attention and resolve conflict as assessed by the Stroop task. We also found that there was increased activation of brain regions that support the performance of that particular task at hand. Moreover, in the sub-analyses, and for me, I'm actually most excited about this potential finding, is that we found that there seemed to be effective resistance training on reducing the progression of white matter lesions, or also known as silent strokes per se. So your brain, again, is an organ that's very vascular, and very often the small vessels that feed deep into the brain can be affected as you age, okay, especially if you have hypertension or diabetes. And as a result, certain areas of your brain can become ischemic or experience ischemia or lack of blood flow momentarily. And that can result in either a TIA, a transient ischemic attack, or more of a permanent damage known as these subcortical lesions. And typically when people have these lesions, they are at greater risk for developing dementia and as well as impaired mobility. And as far as I know, we're the first people within an RCT to show that with exercise, you can actually reduce the progression of these lesions over time. We also then did perform another study looking at resistance training, but now among older women with MCI, and very similar to our results in the healthy cohort, we found that resistance training had a benefit for executive functions, but also for memory, specifically remembering faces and places. And the third piece is using functional MRI, again showing that there's increased activation of brain regions that does support the memory of faces and places. And so in summary, I would conclude that both aerobic and resistance training are beneficial for both cognition and brain health, even among those individuals who are at risk for dementia. And while I haven't had the time to present sort of the findings or evidence today, but there's also a suggestion to show that exercise could be beneficial for those who've had a stroke in the past in terms of cognitive outcomes. Another piece I want to highlight is that the evidence would suggest that starting to exercise in late life is not futile. So even if you have been sedentary all your life, that is no excuse to remain sedentary, because the evidence would suggest that even if you start now, you could reap benefit. Obviously, just like RSP investments, the earlier you start, the more benefit you gain, but it's better to start than to never to initiate healthy behaviors. So the last piece, and I only have 1 minute left, I just really want to highlight the fact that I do think the dose of exercise that's necessary for brain health is highly, highly feasible for everyone, certainly everyone in this room. So a very common question I get is how much daily physical activity is necessary? So is it 30 minutes, 60 minutes? What do you guys think? Can I just get 1 or 2 suggestions? 60 minutes? Okay, and I'm not surprised because that's widely recommended. Okay, now, what does the evidence suggest? So first of all, in terms of the evidence I already showed you from randomized controlled trials, we're talking about 2 times, 3 times per week, right? That works out to be around 20 to 30 minutes per day. However, the limitation of randomized controlled trials is that they're pretty short term. The longest might be 2 years, but if we're talking about, can we actually alter the trajectory of cognitive aging, we need longer observations. So I'm going to take data now from cohort studies or population studies. And a really nice population study that was published in 2010 found that even if you just walked approximately 1 kilometer per day, you can actually maintain brain volume 9 years later. And that maintenance of brain volume was associated with the reduced risk of developing dementia. So what is 1 or 1.03 kilometers exactly, that's what it worked out to be, look like? And I want to work this out for those of you who, again, want to be active, but for whatever reason haven't been able to motivate yourself. So approximately 1 kilometer per day equates to just over 2.5 laps around the standard track, okay? Or 10 city blocks. Now, if we're talking about time, which is a constraint for many of us, Even for an otherwise healthy older adult, a 1 kilometer walk works out to be just around 13 minutes of your day. And even for a more frail older adult, that works out to be a 26-minute walk. Okay? So really what I really want to bring home is that physical activity is a legitimate medical therapy for reducing the risk of dementia. The degree of benefit that's been observed across many studies does exceed the magnitude observed for any pharmaceutical agents to date. Okay? And the last piece is that reducing physical activity by 20% can actually prevent 1 million cases of dementia worldwide. That was actually projected in a paper in 2011. However, I think all of us can also agree that even though we know these facts, physical activity still is underutilized and sedentary behavior is increasing. So I would really encourage all of you who are active is to encourage those of you around you because, humans really mirror people around them. And one last slide is, the last plug I want to put in is that if you think you can't put in 30 minutes per day for yourself, reverse the psychology. Make the goal that you're not lying down or sitting for more than 23.5 hours per day, okay? When you reverse it that way, you really do feel a little bit silly about that, saying, I don't have time, all right? And the last piece is that this is an approach that's been very popular now in cancer prevention, whereby we're not talking about 30 minutes continuously. Build the activity in, okay? So even if it's 10 minutes in the morning, 10 minutes at lunchtime, 10 minutes at dinner, you're still going to get protection. And really, there is emerging literature to show that you could be a gym rat, go to the gym for an hour, work your heart out. But if you're sitting for 10 hours a day like myself, you're probably not doing much benefit for yourself. It's much better if you can actually break out that activity throughout the day and reduce your sitting time. Okay? Otherwise, I just want to conclude physical activity is great for the brain, and that the benefits extend beyond what I've talked about today. Thank you.
Thank you for that entertaining talk and hopefully practical advice. As my teenage children constantly remind me, I am often wrong. So turns out my prediction of staying on time has been completely invalidated. But I'm still hopeful. We still have one more candidate. So it's a great pleasure that I welcome Dr. Julie Robillard, who's assistant professor in neurology and part of the UBC National Core for Neuroethics. And this is a very productive group at UBC, and I'm very excited that she's going to talk to us today about the intersection of dementia and particularly evolving social media and online resources for dementia and how that's going to play out in the future. Thank you.
Hi. Thank you for the introduction. I'm very happy to be here today to talk to you about online resources for patients and family, and I'm grateful to the organizers for this opportunity. So the roadmap for the next 15 minutes, I realize I'm competing with lunch, so I promise I'll stick to it. I'm going to talk briefly about online health, and then I'll show you some data from my research looking at self-assessments for dementia that are available online. And then we'll talk a little bit about websites about the prevention of dementia. And then I'll end with some tips and tricks on how to navigate online resources about Alzheimer's disease. So I'm sure a lot of you in this room are already engaging online and asking questions to Dr. Google. You are not alone. In the younger age demographic, it's nearly 100% of younger adults that are online. For the older demographic, 65 and older, we're looking at over half. So it's still quite a bit, and these numbers are growing every year. We know that internet users seek information. We know they seek health information. In the next 60 seconds, Google is going to receive 2 million search queries. We also know that 80% of people who go online specifically to seek health information. We also know that internet users like to self-assess their health. Over a third of U.S. adults go online to establish whether they or someone they know suffer from a specific medical condition. That can take many different forms. You can go into Google and punch in your symptoms, but increasingly the online environment is catering to that need and is producing quizzes and tests that you can do to assess various things. And in my lab, we look at these behaviors very closely because we believe that this is important, in part because what we do online, increasingly we're finding out, affects what we do offline. So this impact can be positive. You might have read a media article about Dr. Liu Ambrose's research and exercise and say, you know what, I'm going to start walking 1 kilometer a day. But it can also have a negative impact. So you might find a website that's selling supplements and unknowingly start taking supplements that interact with your medication. So the impact can go both ways, and there's a lot of work right now trying to assess how people use online information. So moving on to some studies about self-assessments for dementia. So if you go online right now on Google and you punch in free dementia test, you'll find quite a few. And so one of the research interests in my lab was to evaluate the quality of these assessments. So how good are they and how ethical are they? And so in order to do that, we did some information mining. So we went on the internet and we retrieved some websites that had tests that were freely accessible. And then we did an analysis of them. And the way we analyzed them is by running them through expert panels. And so we used 2 expert panels. Each of them had a neuropsychologist, a clinician, a specialist in human-computer interaction, and an ethicist. And we ran by them the 16 tests, and we asked them to rank various criteria from a rating grid that we developed. And here are some of the characteristics of the tests that we found. So we analyzed 16 total. These tests were hosted on various types of websites, news sites, entertainment franchises, academic sites, all sorts of different websites. The monthly traffic to these websites could be quite high, up to several million unique visitors a month, so that we know these tests are getting viewed, certainly, if not used. The estimated time to completion for the test ranged from 2 minutes to about an hour, so the internet is pretending to be able to tell you whether you have dementia in as low as 2 minutes. And we know that 13 of the tests were designed to be self-administered, so you could do the test for yourself. 3 of the tests were designed to be administered by a relative or a caregiver. And the tests roughly divided into 2 kinds. One kind where you were asked questions that we called questionnaire. What we mean by that are questions about your risk factors, your family history, and your lifestyle habits. And 10 of the tests were performance-based, so for these tests you actually had to complete a cognitive task or a memory task. So the first thing we looked at is whether these tests were scientifically valid. And what we mean by that is how similar are they to the actual tests that we use for dementia diagnosis in the clinic. And we used 4 criteria that I'm showing here for these criteria. And you can see our expert ratings on the left range from 1, which is very poor, to 10, which is excellent. And 4 of the criteria that we used for validity were whether the test content was appropriate to give any information about dementia, whether the breadth of the test was appropriate. So we know that diagnosing dementia is a lengthy, multifaceted process, so we're looking at whether the test reflected that. We looked at whether the questions in the test were based on current peer-reviewed evidence, so whether they were based on recent research, essentially, and whether the test had test-retest reliability. And what we mean by that is if you do the test 3 times on 3 separate days, are you going to get the same result? Is the test true to your actual performance? And you can see that the scientific validity of these tests is quite poor. So for all of these criteria, we're looking at scores under 5 by our experts. And so the take-home message for that part of the study is that most of the tests do not, in fact, provide useful information about cognition or dementia. So they can be fun and they can be something that you're interested in doing, but you have to know that at the end of the test, it's not likely you'll get actual information that will be useful to you. Next, we looked at whether these tests were ethical, and we had 8 criteria under ethics. I'm showing you 3 here. Same rating, 1 is very poor, 10 is excellent. We looked at whether the tests had a conflict of interest. So, for example, were they being used as a marketing strategy to sell you something, a product, a supplement, or a book? We looked at whether there was a consent process in the test. So similar to what you would experience at the clinic, was there a process that told you what you were about to get into and what were the outcomes and what are the implications of these outcomes? And we looked at whether the test disclosed what they were going to do with the private information you might need to enter to complete the test. So for some of the tests, you had to enter your name, sometimes your credit card number, sometimes family history, a lot of very personal questions, and we looked at whether the test told you what they were going to do with that information. And I think it's very clear that on these criteria, the test scored very poorly. For consent and privacy, we can tell you it was one of 2 scenarios. Either there was no process and no disclosure, or there was one, but it was about 16 pages long and font size 3, and you had to scroll for about an hour before you got to the I agree button. And from research, we know that it's very rare that people will actually read these things. So the take-home message from the ethics portion of the study is that some tests can be potentially harmful because the online environment does not require the high ethics standard that we have for similar procedures in the clinic. So moving on from this study, we've got a lot of media coverage, and that was very exciting for us to raise awareness about the quality of these tests and some of the ethical issues. But one of the questions that I got a lot from reporters is, what if I had a good test? What if I developed an excellent test and it read your paper and it looked at all the ethics criteria and it addressed all of them? And that's possible. I think we're moving towards an era of computerized clinical procedures. So it's not impossible that a test would be good. The problem is that then this test is sitting online in an environment among 16 other tests that are not very good. And then the burden ends on the target user to determine which is the good test and which is not the good test. And we know that can be very difficult because on the online environment, it's fair game. You can pretend you're anyone you want. You can pretend you're Dr. So-and-so from whatever university. So it can be very difficult to identify high-quality information, and I'll come back to that at the end of the talk. So I'm just very briefly going to tell you about a study we're doing right now looking at websites containing prevention information about dementia. If you go online and you're not looking to self-diagnose specifically, but you're just browsing for health information, you might find some information about the prevention of Alzheimer's disease. This is an example from Dr. Oz's website, and he has a 5-step Alzheimer's prevention plan. And so we know these resources exist, top 10 tips to prevent dementia. We know they're out there, and so we wanted to look at the quality of these resources. And so we retrieved some websites. 308 websites had information and matched our criteria. And so far we have 100 websites analyzed. And we looked at both the quality of the information and also the type of advice that was being given out. And if you want more information about the study, I invite you to visit the poster by my student Tanya Feng, who's been doing incredible work on this, and she'll be happy to tell you more about it. Just a little preview, I can tell you that the advice fell mostly into 5 categories, so nutrition advice, exercise, lifestyle changes, social activities, and cognitive involvement. And what we did is we took a subset of this advice and we ran it by Dr. Lee, who you heard from this morning, and he told us whether he thought it was good advice or bad advice, and I can tell you it was definitely a mix. So the take-home message from this is that high-quality information and misinformation coexist in the online environment. So always keep that in mind and always be aware that there is misinformation out there. So with that in mind, I'm going to give you a few tips and tricks on how to find good quality websites versus what to be more concerned about. And so here are some indicators of qualities that you can look for when you're browsing online. The first indicator of quality is that the website is recommended by your physician. That is usually a very good sign. The second indicator is that the website is recommended by a trusted source. And what I mean by a trusted source is not necessarily your neighbor, but organizations like Health Canada or like the Alzheimer Society of BC or the Alzheimer Society of Canada, the websites that they link to will likely be of good quality. Another thing to look for when you're browsing for online health information is whether the information is balanced. And what I mean by balance is that it's using cautious wording, things like something may help you or can help some people, websites that list the pros and cons, websites that talk about the limitations of the studies they're relying on to make their claims. So those are all suggestions that the information is balanced and that it may be of good quality. Another indicator is that if an author is listed along with credentials and contact information, and I'm putting a star next to that one because it is not always true. So some high quality information will not list an author and some information will list an author but will not be of high quality. That said, if they're listing an author that you can verify is actually working in the field of Alzheimer's disease at actually a real university, that is a good sign. And then the last indicator to look for is a list of recent references that support the claims that are listed. And so, for example, if a website is saying you should walk 3 times a week because it might help you prevent Alzheimer's disease, you go to the bottom and then you look at the references. I'm putting a star next to that one for 2 reasons. You can find references that will support almost anything. So it is not because something is referenced that it is necessarily true. That said, you can have a look at what the references say and judge for yourself. If you're seeing that the study being referenced has been done in fruit flies in 1936, probably that's not a strong support for the claim. Some red flags, so things to be to keep in mind. So claims of guarantees. This is always something to be skeptical of. If you're being guaranteed anything, be very concerned. There are very few guarantees in this world. Strong words being used, like something will cure dementia or will completely reverse dementia. I can tell you that if we find a cure, we'll tell you. We will tell you. We'll host a little event and we'll put it out in the press. So be skeptical if you find people claiming they found a cure. Requirements to enter personal information. So a new sort of marketing fad that's being used quite a bit online is websites that are telling you they have a secret and you need to sign in or you need to sign up to get the information. And so this is something to be very concerned about. If there's good quality information to support, there's going to be many different sources that are going to be talking about it. So we're not going to keep anything secret. Our policy is to disseminate our research and talk about it. So if you need to sign up for any kind of information, you can probably pass on that one. If the website is selling or endorsing a product, that's definitely a red flag. Sometimes it can be very obvious, like supplements or things like that. But sometimes it could be more subtle, like a book. A lot of websites are trying to sell you books. You can find high-quality, unbiased information. If it's good information, you'll be able to find it on a site that is unbiased, that is not trying to sell you anything. And the last red flag is advice that appears to go against a consensus. And I'm going to talk a little bit more about that one, and I'm putting a star next to that one. So what I mean by that is if you're looking at 10 websites and 9 of them are telling you to exercise more and 1 of them is telling you to watch TV, there's a good chance that the 9 websites are right. So I'm putting a star next to that because that is not necessarily always the case. Sometimes there are new discoveries that might be of high quality but not necessarily have drawn a consensus yet. And sometimes it's not easy to establish what the consensus is. You might not want to browse 10 websites. You might want to just browse one. And so that's something to keep in mind, but that's not necessarily a surefire thing. And that is all the tips and tricks I have. I want to acknowledge my co-investigators on these studies and my students who do excellent work in the lab, poring over all these websites, as well as my funding organizations. Thank you.
Thank you very much. That was a very enlightening presentation about how to wade through the online resources. So a couple of reminders before we move on to the question period, which we'll shorten down to try to stay on time for lunch. Can I have all of the second presenters come up and have a seat at our round table here? Dr. Robillard, Dr. Ambrose, Dr. Wellington, thank you. And while they're coming forward, let me remind you that you do still have those cards in front of you. If you're interested in signing up for future notices for this research forum, then fill out your contact information and place that in the contact box that's in the atrium. If you're interested in participating in future research studies, that's a different box. So you should put that in the research box. So the information, if you think you're putting your information in for a contact, it won't be for research. They're distinct boxes. So please, you're welcome to participate in both. Let me just start off with a couple of questions here. A question for Dr. Chiricilios Ambro. Please advise how an early MCI patient takes part in aerobic resistance training, and are there programs like this outside of the UBC area? And also for any non-English speaking programs. How does an early MCI patient participate in these programs? Are there programs outside of UBC? And in particular, are there more culturally specific programs, non-English speaking programs that might be helpful?
So first of all, for community-based programs, a really good exercise program that combines both aerobic and strength and also balance, and so a multimodal exercise program is the OsteoFit. I'm not sure if I'm sure there are people who are already aware of the program. It's offered throughout the province, so in terms of culturally or ethnically sort of targeted, again, certain communities have certain ethnic demographics, so I would imagine those community centers may be appropriate. There's also the Changing Aging program that is now being slowly translated beyond UBC. So I believe they have a first satellite clinic or center at Dunbar Community Center, and that's actually a really nice program because it's kind of a hybrid between group training and individualized training. And it also does incorporate a lot of strength training, which I actually found to be the most difficult to find as a resource within the community.
Thank you. There's a question here for Dr. Wellington. Saying that it's great to see concussion-related research. Are there any studies, research studies being conducted with respect to the links to adult onset of vision problems with concussions?
That's actually a really good question. I don't know if there are any clinical studies ongoing right now looking at concussion and vision problems. Certainly there are studies being conducted on how keeping in a quiet, dark room after concussion can sometimes help people recover in the very early stages after a brain injury. But long-term vision studies, I'm not aware of any.
Okay, this is sort of open to anybody. There's two questions. One is continued social interaction a factor in reducing the chance of Alzheimer's disease? And the other one, is there any evidence for meditation?
So in terms of socialization, yes, absolutely. So in terms of healthy cognitive aging, which is healthy aging in general, there is very good evidence that if you maintain social connections as you age, it's beneficial at all levels, both cognitively, but also mentally, okay, and physically, because I think you end up going out to be engaged. In terms of meditation, I think we'll switch it to mindfulness potentially. I think there's different wordings now that's being used. The emerging literature actually is pretty powerful. There is a suggestion that with mindfulness training or meditation, there seems to be a benefit. But again, the evidence is emerging, so I guess I'm kind of sitting on the fence, but it is more positive than I think would have expected. That's been published in the last 2 years or so.
Okay, I think we'll wrap up now because of the sake of time. Thank you for your presentations and for your responses.
Thanks. Are we okay? Well, I know when you came in this morning, you were probably thinking at the end of the session, I'll go for lunch. But based on what you've heard, I know you won't go for lunch, you're going to go for a walk. Or maybe you will go to the gym and do some resistance training. So I want to just come back in closing to some of the documents that you have in front of you. I was asked to comment on making donations and supporting the good work that you've heard of this morning. And I would draw your attention to a sheet that tells you about donations. So it is possible to make donations, quite important. When you do, that you contact Stephanie Forjax. Stephanie, are you still in the room? It is. Stephanie's outside. She'd be happy to meet you. But alternatively, you've got a phone number and a bona fide website that you can trust. So this is an opportunity, and it helps to please specify that it's for the Alzheimer Clinic. And if you would like to make it more specific to a particular program that you've heard about this morning, please do so. That helps a great deal. There is a document called a feedback survey. This helps us a great deal. This program, as much as we faculty, staff like to see each other, it's really a program for you and the community. So we welcome your feedback. We'd like to meet your needs. And if you fill this out, it helps us understand what the needs are and what we might be able to do better to make this an even better program. Hopefully the research that you've heard about and the way that we're driving a research agenda leaves you feeling encouraged about what lies ahead. Just a reminder that we've laid out all of our current research programs. In order to make progress, we need participation. I think at the count ahead of this, we recognize that there are about 350 persons presently involved in some of the research programs that you've heard about, but it really will take a community effort in order to advance this. So those are some of the housekeeping issues. I would like to draw your attention to the fact that this program has run quite seamlessly this morning. And when that happens, it means there's a lot of preparation behind the scene. As a clinic structure, we don't have any infrastructure with which to mount these efforts. This is done by clinic team participation. It gets done outside of people's regular activities, and people do so with great willingness. I'd like to particularly acknowledge the steering committee that met weekly, twice weekly, sometimes more often. Emily Dwash, Colleen Guimot, Haka Nygaard, Robin Shung, Maya Lichtenstein, Amy Friedman, and maybe just by show of hands we could give them a round of applause. I'd like to thank all of the speakers. I think this was a fabulous morning with a wide diversity of talks. A round of applause for our speakers. And then it takes one project coordinator to really drive this event. And we looked around the table and I asked if anyone would like to volunteer. And then when we left the table, someone got back to me and said, I would like to do this, and that is Ruby Ma. And Ruby has looked after every matter of detail, down to making sure that they're nicely tied up little gifts for each of the speakers. The room was fabulous this morning with all the papers laid out, with every imaginable detail looked after. We owe Ruby a tremendous thank you, and we have a small gesture for her. If she could come down. Just stay here, we'll both do it. This is just a small thank you from us. Teamwork. It's teamwork. Selfie facing as always, she says, it's about teamwork, but really it's about her leadership on this event that made it happen. I also, as part of the detail, you probably saw the Seattle Seahawk colored t-shirts that everyone's wearing. Go Seahawks, go tomorrow. But we managed to attract high school students to volunteer today wearing these green t-shirts. We hope that they will not only take interest in the volunteerism, but maybe even in some of the science, and we never know where the next generation of scientists that we'll be talking to are coming from. So we take great interest in those that volunteer with us, and a special thanks. And most of all, thanks to you for coming. I started the day by saying, oh my God, what if nobody turned up? We have filled the room. It's been a great morning. Thank you for coming. We'll see you next year.
We're parked at the side.